So yeah, thanks, Nellie, and everybody else, all the organizers, for giving me this opportunity. As Nellie said, yeah, we're all aware this is a growing issue, and I think for me, my journey with this started several years back when I thought, yeah, I know it's a problem. Again, like so many people, want to do something, don't know where to start. The exciting thing that I found when I started looking into this is there are some really, really exciting opportunities for us as both providers and researchers to make a difference. And there's using a planetary health lens to do almost everything we do in healthcare actually can lead us to a better system that's better for patients, better for the planet, better for us as providers, and better for the system that saves money. So that's the spoiler. I'll get into more details, but this is why I'm so excited to be here sharing this with all of you, because I really believe that this is a really important route forward. So I have no conflicts of interest to disclose. I have had support from East Kootenay Divisions of Family Practice and from Cascades and from Health Quality BC, as well as Interior Health on this work. A lot of people are excited about it. I just want to acknowledge that I'm presenting today from the traditional territory of the Ktunaxa people, near what's now known as Kimberley. And as temporary guardians of this borrowed land, we have an incredible responsibility to take care of it the way the Ktunaxa people did for 10,000 years before colonization. What the Ktunaxa people seem to have known that we seem to have forgotten is that we're not separate from the environment. We're part of it. We're part of nature, and we can't be healthy if our environment isn't healthy. And so, in fact, we know now that ecological determinants, as well as social and structural factors, have a much bigger effect on our health than the actual healthcare system. So threats to our environment are threats to our own health. And again, many of you are familiar with this now. Human-caused climate change caused by the excessive burning of fossil fuels is causing record-breaking temperatures year after year. This year again, highest temperatures ever. Several years back in Paris, all the world leaders agreed we got to keep this warming down to 1.5 degrees. We're already at 1.2, and if we don't do something, we're headed for 2.8 within the lifetime of our children, being born today. Many experts believe that the next 5 or 10 years are critical. But we all know this because we're living it. Anybody who lives, well, almost anywhere in the world is experiencing these effects directly in their own communities. So as the planet gets sicker, we get sicker. And at the same time as climate change is increasing the healthcare needs through air pollution, heat domes, and vector-borne diseases, it's also worsening health inequality, and it's reducing health system capacity by impacting healthcare facilities and also impacting healthcare workers through burnout, more frequent illness, and evacuations. So despite our mandate to protect health as a healthcare system and to do no harm, we have known for many years that our healthcare system actually contributes to a lot of these environmental problems. About 5% of greenhouse gases, both globally and in Canada, are attributable to the healthcare system. So in our pursuit of trying to increase health, we're inadvertently causing harm to our patients. And a lot of people assume, well, this is just a necessary sort of byproduct of providing high quality healthcare. But I love this graph because it really shows us that in Canada, although this is a graph that compares life expectancies in different countries around the world to the amount of greenhouse gases we produce in order to achieve those life expectancies. So you see Canada, in terms of quality of care, life expectancies in Canada are similar to all those green bubbles, the European countries, so very good. However, if you compare us to a country like France, we're doing this at a much, much, much higher environmental cost than, again, a country like France. And so what this tells me is that high quality care is, high quality, low carbon care is possible. And it also tells me we've got a lot of room for improvement. And it also tells me we shouldn't be going to do more of whatever the US is doing down there at the bottom. So many would argue that an environmentally sustainable healthcare system is not only possible, but it's actually a prerequisite for a high quality care system. Without taking environmental effects into account, we can't really say that we're providing high quality care. So we need to embed sustainability as a core component of high quality care as an interconnected cross-cutting theme across all dimensions of quality, making the case that environmental sustainability is essential. The first step in doing this really is to understand where in our system the biggest impacts come. And Nellie sort of alluded to this in the introduction. Typically, we think about recycling, we think about heating and cooling our buildings, we think about turning off the lights when we think about trying to be environmentally sort of proactive. But several studies in many countries around the world have now showed us that the biggest part of our impact is what Nellie referred to as invisible, meaning it's outside the walls of our hospitals, the energy used upstream in the supply chain to generate all the materials and supplies and things like medications. That's where our biggest impact is coming. So if you look at this graph, in Canada, the biggest carbon impact comes from medications. And as certainly, I don't know how many primary care providers there are in the office, but or in the room, but in primary care, the total is 60% that of our footprint that comes from medication. So that kind of thinking is a little bit new. So to give an example of what I mean by this upstream invisible impact, think about what happens when a patient goes for a lab test. All kinds of single-use disposable materials are used to collect the sample, then store it, ship it, process, analyze, and dispose of it. And then think about all the energy and resources used to create each one of these products. Raw materials need to be extracted, processed, manufactured, and shipped. It starts to make sense why this invisible to us upstream impact is so large. The same thing applies to medications and all the other products we use in the healthcare system every day. And that's why, again, as Nellie said, everything we do almost has a footprint. And although many people assume that thinking about the environment may mean that we have to compromise or sacrifice other values, from what we've been seeing, and as I mentioned in the introduction, when we use this planetary health or environmental sustainability lens to improve our care or to try to save the planet, it turns out the things we do also tend to be better for people, better for providers, better for payers, and better for the system overall. So it's a win-win-win. That's, again, why I'm so excited about it all. We also really need to expand our concept of how we can reduce our carbon footprint. What does environmentally sustainable healthcare look like? We need to think about different ways that we can have an impact far beyond recycling. So the UK Centre for Sustainable Healthcare is way ahead of us on this, and they've identified 4 key principles for sustainable healthcare: reducing unnecessary care, empowering patients, health promotion, and environmental alternatives. And if you're interested in these, the little QR code will link you to a document that we produced earlier in the year aimed at primary care clinicians that expand on these things. But what I want to talk about today is how these same principles can be used for research and how we think about reducing our impact when it comes to research. So the most obvious principle is one we usually think of: reducing physical waste and saving energy by choosing more environmentally friendly products or options. And in order to do this, we need to be paying attention to where these things might crop up in our own research work, such as using digital or virtual instead of paper or in-person interviews or surveys. Just as important, though, is in the research we choose to do. A lot more research is needed to look at environmental impacts of different things to help us know which options are actually better. There have been a few studies looking at the environmental effects of research. This was one done by the Sustainable Trials Group, and it was called, they basically looked at just one trial, a large trial, a multinational trial, 10,000 patients. And they found that just this one trial generated the equivalent CO2 of 160 people for an entire year, or 525 transatlantic flights. This was just one study. And so if you sort of extrapolate that and think about CIHR, again, even just in Canada, $1.3 billion worth of research is happening. If only one study generates this much of an impact, you can start to imagine how much overall impact the research industry is having. And significantly, this trial was done before those other studies I talked about. And so they didn't actually even consider any of the impacts of the medication or anything else. They only looked at the energy being used in research facilities and the energy related to travel. The actual impact, if they were to do the study again today, would probably be even much bigger. The same trial group also estimated, they looked at all the trials registered at the time on clinicaltrials.gov, and they figured out that the carbon emissions from the trials currently being listed would be about the same as a third of the annual emissions of an entire country of Bangladesh. So maybe not as high as some other countries, but still significant. A simple thing we could certainly all do is think about doing what we're doing right now, meeting virtually instead of in person. COVID taught us this is very possible and in many cases preferable. Certainly if you're debating about going to a conference, and especially if you have to fly, you can see that the environmental impact is enormously different. We also need more research like this. Kevin Liang, a brilliant budding young researcher, during his medical school interviews for residency, calculated the carbon footprint of that, they call it the CARMS tour, when all the medical students fly all over the country to do interviews at different universities when they're applying for residency. And he calculated that just in 1 year alone, the year that he was applying, each applicant had the equivalent footprint of 35% of an annual Canadian household, just from that CARMS match. And so he and his colleagues did this study, and they've been working to, they call keep CARMS virtual, because there's probably no reason for that to be happening. We also need more research like this, giving clinicians and policymakers and procurement specialists the data they need to make better decisions. We have to be able to show them the numbers and show them that environmental alternatives are often better in many, many different ways, including cost. The second, and maybe one of the most important principles, is about reducing unnecessary waste in research, similar to reducing unnecessary care in our clinical practice. It's estimated that about 80% of the research we do is considered unnecessary, meaning it doesn't ultimately result in any benefit to patients. Doing research that's duplicating other work, is underpowered to answer the question, or is never disseminated, leads to cost to funders, burdens on researchers and participants, and of course, cost to the environment, all without any likelihood of patient benefit. Eliminating the wasted research would free up more funds and time for us to spend doing more high-value research. And I need to clarify, when I talk about wasted research, I'm not referring to research that's, that ends up with a negative result. That's just a scientific process. But it's talking more about research that's done poorly, so it doesn't actually contribute to our overall knowledge base. The Lancet, several years back, identified waste in research as a problem. And they ran a great series on reducing waste in research back in 2014. And their reward statement said, "We recognize that while we strive for excellence, there's much that needs to be done to reduce waste and increase the value of our contributions. We maximize our research potential when we adhere to these 5 principles." And really, it's a lot about, doing good research. Surprisingly, some of the studies have shown when they looked at these things, although it should be obvious, it turns out that even in high quality journals, some of these basic principles aren't always being followed, such as this study, which looked at making use of existing evidence, doing your homework. It's not as standard as it should be, even in high quality journals like these, JAMA and The Lancet and New England Journal. This study, entitled "Many Reports of Randomized Trials Still Don't Begin or End with a Systematic Review of Relevant Evidence," found that many didn't reference existing reviews or claim they were the first to be asking the question when they weren't, or failed to modify their design based on previous evidence. The third principle of environmentally sustainable healthcare and research is empowering patients. In the research context, this means that we need to study things that matter to the end user, in this case, the patient. And in order to do that, we need to ask them, what matters to you? And we need to use patient-oriented research. We need to engage them, patients, early in the process of deciding what questions to ask and how to ask them. But again, sadly, this isn't always the case. Although it's gaining traction, many studies, especially commercial trials, aren't asking questions that really matter to patients. Obviously, industry-sponsored trials have a different objective, a profit motive rather than a goal to improve patient outcomes. But when they looked at trials done by industry and non-commercial groups and then compared them to what patients said mattered, you can see the dramatic difference in the priorities. Patients on the left-hand side thought things like education, service delivery, non-pharmacologic conventions were the most important, while the commercial studies were heavily weighted towards drugs, vaccines, and biologicals for obvious reasons. Unfortunately, whether it's good for patients ultimately or not, much medical research does happen in commercial settings. And if we allow the commercial industry to drive the research agenda, much will be missed, including the things that actually make the most difference to the population and individual patient health. Because, as I mentioned earlier, patients actually understand that very little of our health, maybe only 20 to 25%, actually has anything to do with this healthcare system. Most of the determinants of health are social, biological, environmental, or behavioral. And patients understand this. They know what really matters, and they know that no matter how many expensive drugs are developed, they make very little difference without adequate security of income, food, housing, and social support. And that leads us to the last and maybe the most important principle about how to decide what our research system should look like, what research to prioritize in order to have research that will benefit most people and cause the least harm to the environment. Generally, prevention and health promotion is more effective, less expensive, and more sustainable than sort of high resource intensity tertiary care interventions. This concept of the importance of prevention and health promotion is reinforced by another framework designed by Dr. Andrew McNeil and others from Vancouver. And it lays out the key parts of developing an overall sustainable healthcare system. The first concept, again, is about reducing the demand for health services in the first place by keeping people healthy. And given the current financial unsustainability of our healthcare system, the fix can't be ever more expensive technologies and medications. We simply can't afford it. So we need to ask ourselves, given our limited resources, how can we prioritize our research to focus on things that provide the most benefit for the greatest number of people in a financially responsible way? For example, when we're thinking about overall human health and environmental impact, it's interesting to compare basic bench research compared to applied or clinical research. Now, of course, bench research is really important, and it's led to some astonishing and important breakthroughs. And so most funding is still dedicated to bench research, but one study found that for every 25,000 studies, there was only one that led to a meaningful impact on human health, and typically it took 20 to 25 years. Much of this is funded by industry again and focused on conditions with the most profit potential. Applied research, on the other hand, results in more rapid impacts and has consistently been shown to have larger health, social, and economic effects than preclinical research. And although healthcare in general has led to great advances in human health and well-being, in countries like Canada, we've now reached a point where many parts of our system are actually causing more harm than good, and more is not always better. We've been led down the path of more and more expensive high-tech solutions, but this is unsustainable, and although it increases economic growth, it's not contributing to an overall increase in well-being for the majority of people in our society. Instead, we're seeing more mental illness, poverty, social disruption, and environmental degradation. And our society's overconsumption and misuse of many different things, whether it's alcohol or tobacco or fast food, and our failure as a society or a healthcare system to help control or limit this harmful consumption is leading to more health problems, which bring people into the health system, where our misuse of healthcare resources and technology also leads to more harms to patients, the planet, and our communities, which is leading us back to more harms and then back into the system. So this is an important thing for us as researchers to consider. How do we prioritize our research to prevent this ongoing and worsening vicious cycle? There's a great article written by Kaveh Shojania, and he asked the question, what problems in healthcare should we be tackling as the world burns around us? He had several examples. But the upshot is, when we let commercial interests control research agenda, we get ever more technological and pharmacological solutions. We enable overconsumption of harmful products. But as researchers, we have the opportunity to disrupt this cycle. Research efforts might better focus on increasing resilience of the health system, devising better models of care, or dedicating efforts at addressing upstream social behavior and structural determinants of health that would offer larger impacts on healthcare quality and population health than continuing the quest to find the silver bullet pill for every ill. If you think of these examples, we could work on reducing air pollution or design more and more fancy inhalers. We can look at addressing adverse childhood experiences through social housing, income, universal daycare, or just keep developing more antidepressants. You get the idea. We already know many of the solutions. For example, plant-based diets is thought to be the most important thing that all of us can do, both for our health and for the planet, yet it's not widespread. More research could help us better understand how we can translate this knowledge into action. The NIHR in the UK has developed guidelines on reducing the carbon footprint in research. And basically, it's all about just doing good research, do high quality research, and think about your environmental impact at every stage of that research and try to reduce it. And then the other part, again, is choosing what we research. What can we do that increases overall health and well-being of our population and promotes a more long-term sustainable system? Most of all, we need to do it for our kids, like these guys, my own kids, and all of the others of their generation. They don't really deserve any of this. We need to ensure that we not only have a sustainable healthcare system, but also a livable planet to pass on to them. And I believe that we in healthcare have one of the most valuable opportunities to be key players in this transition. Because with health as a shared or common value and a purpose, and with health professionals like us as some of the last remaining trusted messengers, I think we still have an opportunity to unite people around the science and to help guide this shift back towards a better and more sustainable future. That's it. These are the guidelines broken down in a bit more detail if you're interested. They're at the end of the presentation. Okay, all I've got. Any questions?
Thanks, Dr. Hill. That's the second time I've seen it, and I enjoyed it once again. I'll start off with questions, so feel free for everyone else to add questions in the chat box. Panelists can come off mute as well if you choose. I'll kick off. So prevention is obviously a big point of your presentation. We can remove a lot of the harm if we don't actually engage in polluting practices. And so maybe this is a question that is maybe a bit outside your own scope as a clinician and researcher, but it comes to the will to take action or to reduce certain activities. And I'm just wondering what will push us in that direction, kind of more of a philosophical question, perhaps. What will push the masses to use less, to reduce certain activities, in your mind?
So I'm not 100% clear if you're talking about sort of what will move people to be more environmentally friendly, or to be more to do more of the health promoting activities like diet and exercise. Just so I know what you're asking. Sorry.
Yeah, I would say both. I think they're connected.
Yeah, you're right. How to change behavior. Yeah, if I knew that, I'd be a multi-billionaire. But I think, I mean, really, the simple thing is probably, funding. Right now, in our health system, we have about 3 to 5% of our healthcare system budget that's dedicated to prevention and promotion. So that's a good start. Like if we shifted that, I think, money doesn't solve everything, but it could solve a lot of problems. And again, dollar for dollar, I think there've been lots and lots of studies that have shown that every dollar invested in prevention, has a much bigger impact than the dollars we spend pulling people out of the river and then throwing them back into their environment, where they go right back into the same, situation and sort of habits that led them to cause them to fall into the river in the first place. So I mean, that would be the simple answer. And more research, so more funding for more research to better understand, how to shift that behavior. I mean, the marketers know how to do it. They sure know how to get us to do what they want us to do. I think we know, but we haven't really crossed, there's not enough work between silos. We need to have enough money to hire those marketers that Coca-Cola uses, and we need to hire them to sort of advance this agenda for good instead of for, well, less good.
Thanks, Dr. Hill. We'll take a question from Dr. David Snadden.
Hi, Ilona. What a fantastic presentation. Thank you very much. There's a little tick list in there when I was ticking off all the things I'm doing to try and help the environment. But my question is, as a rural physician, this, and I was thinking, why is Canada so different from France? And one of the issues in the rural areas is the geography and the transport issues. And I know we're using real-time virtual supports and things which do help people. But have you any thoughts about, the footprint of our patients that have to travel for specialist treatments or investigations or consultation? I'm thinking of, having to drive 10 hours for some people to get a CT scan. How do we deal with that?
Yeah, it's a tough one for sure. And you're right. I mean, maybe it's not apples to apples when we compare us to France, although we also have a probably cleaner energy grid than they do. So, could go either way. But I mean, I think we're on the right track with a lot of the virtual care that's happening. I think more and more and more. Again, COVID was that in that sense a blessing, that it really allowed us to realize, oh, we can do that. And I think it is happening. I think it could be happening faster. And then I think, again, a lot of the other things that the RCCBC is supporting, more rural local capacity to be able to do more things, helping people in big cities recognize that we can do stuff, that they don't need to see our patients, every 6 months. For a whatever check that we're perfectly capable of doing. So I think continuing to do, like I said, all the great things RCCBC is already promoting, I think you're on the right track, and I think we need to do more of that.
Thanks very much.
I have another question, and this time it's from Dr. Bob Woolard, and I'll put him on. Bear with me 1 second. There we go. Go ahead, Bob. You had a question?
Thank you very much for the depth and breadth of what you were able to condense and distill for us, and I really appreciate you're an inspiration to us. My question relates to what we've learned from smoking cessation literature, and that is that when we wag our fingers at the smoker, and it's at best neutral, if not actually counterproductive. And my question is your thoughts about the transition for creating a sense of hope, a sense that you can contribute, not that you must contribute, but you can contribute to things. And I just wonder what your thoughts are in relation to what we learned from smoking cessation.
Yeah, well, I think you're absolutely right. Inspiring hope is probably the most important thing. And yeah, finger wagging almost never works. People need to want to do these things. And it's hard. I always hesitate to include the scary slides at the beginning because I don't want to try to scare people, or but it's it's a balance. I think we need to make sure people are aware of how urgent this issue is. But I'm never sure if I do it enough, but I really like to try to at least among other health professionals, help us all recognize what an incredible opportunity we have to help both the environment and the healthcare system all at the same time with these same actions. They work and they do it all. And again, how to encourage people to do those things, even, I'm not sure, although the reduced workload is my biggest selling feature, I think, for providers these days. Is like, hey, your task box could be 30% smaller if you think, pause before you tick more boxes, because they might lead to more and more and more work down the road. And so with health professionals, that's the way. I haven't really tried to start bringing this out to the general public, but I certainly in my own practice, I find that patients, when they know about, say, meter dose inhalers or something, and they find out the impact, they're excited, like they want to do something. People really want to be part of the solution. And so there's probably a little nugget somewhere in there. But like I said, I haven't really been, talking to the general public about this, been too nervous. Thanks, Paul.
Dr. Hale, that was great. Really appreciate hearing your presentation. I'm sure we all learned something today. Really appreciate it, and thank you.
Thank you, Jason.
All right. So as we transition, we will now be moving into our respective Zoom rooms. So Zoom room A, and it's in the program, can stay here, and it'll be facilitated by Dr. Frank Schumacher. And then Zoom room B, the link is in the program. You'll join Dr. Dave Snadden as the facilitator there, and those sessions will start in the next minute or so. So thank you for joining us at the 4th annual BC Rural Health Research Exchange, and I hope you enjoy the presentations. All right, looks like we're ready to go in Zoom room A. So I'd like to introduce Dr. Frank Schumacher. He is an emergency physician, assistant professor in the Department of Emergency Medicine at St. Paul's Hospital, and coming from Vancouver. Welcome, Dr. Schumacher.
Thank you, Jason. One more thing, I'm actually not just an emergency physician. I also do about 4 shifts a month with RTVS 811. So I have probably talked to, I think probably a third of my work is with patients in rural and remote areas. And I also get to phone emergency departments in all across BC when I warn them or tell them that patients are likely to come in. And when you're talking to somebody who lives in Fort St. John, who's trying to decide, or halfway between Fort St. John and Dawson Creek on a January snowstorm, you realize that when I live in North Vancouver, obviously the challenges that I face here are very, very different than somebody who lives in a very rural and remote part of the province where they were going to an emergency department. The trip itself can be fairly risky at times. So we do our best to try and keep people away from the hospital and try and manage virtually as much as possible. And it'll be really interesting to see. I noticed there's a couple of RTVS presentations, which I wasn't actually aware of, that are going to happen later on, and I'm really looking forward to those. So I'm going to turn the presentation over to Dr. Mike Figurski and wish everybody a good morning.
Dr. Figurski, we
Turn
can't
your
quite
mute
hear
button
your
off.
audio. Still, yeah. And the virtual backdrop is playing havoc. So yeah, we can't quite hear you, unfortunately. There we go. I think we got
Can
something.
you hear me now?
We can certainly hear you.
Okay.
The
Hey,
virtual backdrop, just before you begin, Dr. Figurski, if you want to shut it off, it's a bit, we're
I'll be sharing
seeing.
my screen. I'll just share my screen. That'll be
Okay,
better.
sure. Sounds good.
Hello, everyone. My name is Mike Figurski. I'm a doc. Doesn't look like I'm sharing my screen. Or can you see my screen?
We're just seeing the your browser at the moment.
Great.
So you may just want to, oh, there we go.
Okay. Hey, my name is Mike Figurski. I'm a doctor here in Big White, BC, and also in Kelowna. I've got an interest in open source electronic medical records, and we're doing some work with UBCO trying to develop an open source platform called OpenEMR for use here in Canada. It's GPL3, meaning it's copy left, so it can't be sold, it can't be bought. You can create new uses, features, or instances of it and sell those, but you have to release the code freely to anyone who asks for it. We've got a couple of demo sites I'd like to show you. This is the site that is the basis of our platform. It's OpenEMR, which is the largest open source electronic medical record platform in the world. It's got hundreds of developers, millions of clients, and tens of thousands of active users with a very active community. I was fortunate enough for the last 5 years to be working with Sam Sudheen Jabbar from India, who made it over here in April of this year and has been working me here in the office, literally side to side, to allow us to develop this in-house. I'll introduce him at the end of the presentation, but for now we'll look more at the demonstration sites. One thing we're trying to do with UBCO faculty is develop an inter-faculty collaboration platform so students can learn to use an EMR without using live patient data. Currently, I take 3 medical students a year, mostly 4th year, doing their clinical family practice up at Big White for 4 weeks. And the vast majority of them have said when they were doing their clerkship or learning that they would use an EMR in a doctor's office and just they'd be given login credentials because it was just 4 hours a day, twice a week for a couple of weeks, and it wasn't worth creating a whole new user. And it was easier for the doctor to follow their notes that way. Certainly, this is not optimal, given that learning a new task is fraught with errors. So we're a lot more likely to cause problems with live patient data, either in the hospital or clinical setting, if we haven't prepared students to use an EMR. even more concerning, we're not going to change the way students change information between faculties when they graduate unless we do it baked into their academic program and training. So we've developed this program was a roles-based small group learning tool to create synthetic patients and have them be the basis for learning experience and collaboration between 4 prototypes. So that would be a clinical person who's usually a nurse. That would be a provider who could be a physician or a nurse practitioner or a physiotherapist, anyone who has direct control over patient treatment. The technical person is the 4th role, and the business person, or sorry, technical person is the 3rd role, and the business person is the 4th role, managing office functions like billing and patient coordination. The most functional website now is this one, vemr.ca, which is live and running and gives you an example of how our system works currently. So you can register as a patient. So we'll do that now. I assume everyone's still hearing me and I'm not talking to myself.
We can hear you loud and clear.
Excellent. Wouldn't be the first time. Okay. So once I register, once again, this demonstration site VMR has no live patient health information. There are projects. There's an open source platform called Synthia, which can create synthetic patient data using no real personal health information, even as far as providing lab and information based on geographical context, gender, age, any demographic parameters you'd like. And this can be used to populate a demonstration or learning academic EMR instance of VEMR or OpenEMR for learning and education or research or modeling. So what would happen after registration is I get a one-time passcode on my phone. I would check that and it would confirm that I'm really the patient. But we're not going to go into that. We'll move straight on to the demonstration itself. Now I can log on as a doctor. This is the same VEMR demo site. Doctor are the user credentials. It has administration role typical of a provider. It wouldn't have full administration access, to be able to create new users or things like that. There are a lot of really good things you can do out of the box with this program. One of them is you can create video consults with any patient who's registered using an email or phone number. It has a API Twilio integration, so you can create instant in the EMR video consults to share your screen, show information, receive or transmit documents or data to the patient, to quickly call the patient, to quickly SMS or email the patient, and that email can include attached multiple documents of different formats sent to the patient's email. Now, during registration, because the patient registers on their own phone and confirms registration by their own email, we use these as a primary source of contact and identification. They consent to the use of email if they allow it, voice messages, direct phone calls. Most of my patients are seen virtually first, unless they're injuries or accidents. My main job is the doctor at Big White, so we see a lot of ski injuries there. Of course, it's handy for them because very often they don't need to see someone, they just need to get triaged. So I'll see them virtually the moment they're on our website, and then I can make a plan of disposition, meet them at home, send them to town, call an ambulance, whatever is necessary. As important as anything, this is penance for me. I was the pedo representative for the South Okanagan, the peer mentor, who convinced a lot of physicians to put early phase EMRs into their office, promising benefits that really haven't materialized. Instead, doctors are paying several $100s a month for digitized, to act as a scribe, to digitize their information onto unpublished, organized databases that are out of their control. Because the database for OpenEMR is published, you can run all sorts of different web services on the back end without having to use OpenEMR or any code other than the ones you develop. You can develop simple apps to suit your specific work function. What I found very effective is the golden pair, working directly with a developer here in the office and sharing screens. There's Sam there. I don't know if you can't see. I don't think you can see him either. But literally, he's got the code on the screen, and I can say, you know, change this, put it over here. And in a matter of minutes, I've got a working version that does exactly what I've asked him to do. And that was pretty much my presentation.
All right. Thank you very much. What are the barriers, do you think, to implementing this more widely?
Doctors are physician lock, patient lock. You know, physicians are locked by their vendors where when they leave, for instance, they sunsetted Wolf, as they will with most EMRs, to try to bring someone onto a common platform, probably Accuro or MedAccess or CHR. And physicians who painstakingly put in this patient information for the last 10 or 20 years are asked to pay $1,500 to get their information back, but it's not even in a database that they can use. Each visit is considered a separate glob of text, and unless you integrate it into one of the vendors' EMRs, you're on your own trying to migrate. I think the biggest barrier is a federal law on privacy saying, as they've done in the US, that not only do patients have the right to their information, but it should be in a portable and digital format and machine readable. And then they'll be able to take this glob of unstructured text, pull out recognized entities, you know, have structured diagnostic, medication, therapeutic, procedural lists, without any human intervention.
Great, thank you very much. And in the interests of time, I'm going to turn the proceedings over to Dr. Hannah Nelson.
Just going to unmute myself there and share my screen. There we go. Can everybody see that? Yeah, all right. Good morning, everybody. Thank you to the BC Rural Health team for having me today and for giving us the space to present our research. Today, I'm going to be talking to you about bringing respiratory diagnostics to point of care in remote First Nations communities. Right. I would also like to start off with my own grateful land acknowledgement that our research takes place on the traditional, ancestral, and unceded territories of the Musqueam, Squamish, and Tsleil-Waututh nations. We are fortunate to be partnered with FNHA and to conduct our interviews and our research with frontline nurses in numerous traditional territories across BC. And starting off with a very brief background on healthcare in remote settings. As many of you are very likely aware, providing healthcare in resource-limited and rural settings is complex. Often we are navigating severe healthcare worker shortages, a limited range of services, and concerns of cultural safety. So while FNHA has been innovative in their testing initiative, I'm going to be speaking about these complexities are still important to keep in mind while we're conducting our research. Some background on respiratory illness in First Nations communities. First Nations populations face a higher burden of respiratory viruses, which is exacerbated in northern and remote settings. Because of this, Canadian guidelines recommend that Indigenous peoples should receive early access to influenza therapeutics, which means this population's effective and timely diagnostics are essential. So in response to this, the First Nations Health Authority implemented innovative point-of-care molecular diagnostic testing during COVID-19 in rural and remote communities, utilizing the GeneXpert platform. Following this implementation, our project was to compile lessons learned from the implementation during COVID-19 to inform the expansion to RSV and influenza. Right. First, we designed a review to accompany our principal research. This review is a systematic review of the barriers and facilitators to community-based molecular testing. It serves to both supplement the data we gathered in our own interviews and to provide an overview of the current qualitative data regarding GeneXpert and other point-of-care devices across the world. We searched various databases, screened according to our community-level interest, and analyzed reports thematically. Please feel free to check out our protocol in more detail if you're interested. We have a QR code in the bottom right there. Yeah. At the top here, you can see that we screened almost 5,000 abstracts, 30 full texts, and it had a resulting 6 included studies. On the screen, I have some main results of our analysis, including the locations where the testing was implemented in these studies. While it's important to note that these results give us understandings of implementation factors for existing point-of-care testing, not all of the themes are generalizable to our own research due to some vastly different settings. As far as I know, no studies have been conducted examining point-of-care testing in rural and remote First Nations communities due to the uniqueness of the FNHA community-based testing program. With that being said, one common theme was barriers due to infrastructure, meaning challenges with limited internet access and electricity, which caused lost samples when power cut, temperature regulations required to maintain the device standards, and just a lack of physical space in these remote clinics. Another major barrier, which is shared majorly with our own results, is the workload management. In some cases, due to a backlog of tests needing to be run, they didn't always offer same-day testing. There was also a disruption of the regular workflow and difficulty managing the added task on top of regular duties with not enough staff. The last theme has to do with staff attitudes and perceptions toward the testing, which vary greatly. There was evidence of staff empowerment at being able to test and treat on site, as well as increased awareness for some diseases being tested, like STIs. The staff attitudes directly impact the success of these point-of-care programs, so they're incredibly important, even in our own research. There was also some frustration and barriers due to delays in normal clinical processes, as mentioned, and there was some frustration and lack of confidence in results due to invalid testing, test results within these platforms. Okay. So for our own qualitative research, we conducted 8 semi-structured interviews with nurses responsible for the testing on the GeneXpert in community between January and June. On the right here, you can see all the locations of the sites we recruited from, and each interview was recorded, transcribed, and thematically analyzed to give the results I'm about to present next. And next, I'm going to just read through some overarching themes and quotes from our interviews. So the first theme that emerged from the data was workload burden. And a quote that illustrates this well is as follows: "We're providing these testing apparatuses, but they don't have the money or personnel to man them. It takes regular staff. The other nurses on it are leaving today, so then I'll be the only one. When you're focused on the testing, you can't really run or do anything else other than that." So action points that develop from this are development of micro-credentials to strengthen community capacity. So this is something that FNHA is currently looking into and exploring to help alleviate that workload burden on the nurses. Second is process paradigm shifts between frontline nurses and lab processes. So a nurse has shared that I think the reality of what the expectations were for tracking and running the machine were not aligned with the reality of the day-to-day here. So our action point that followed that is to simplify log processes where possible. So this means any communications about the device really simplified down to easy to follow infographics or briefs that are not just pages on pages in emails, but rather something they can post near the machine that can refresh them as they're doing testing as necessary. Next is community acceptance and excitement. So one of the nurses shared that when people started finding out that, we've got the machine and you can get your result within about an hour, everybody got really excited. And it just kind of made people not as anxious, So this really supported the implementation of the GeneXpert to begin with, and indicated that testing was appreciated in the community and that community members were grateful for both the peace of mind and the diagnostic implications for this. So action points here were to support for further scale up and expansion for RSV and influenza. And I believe now in almost all, if not all of the communities, RSV and influenza testing has been implemented as of today. And then another thematic area is increasing options. So people, just like they would want to come in and get the saline gargle because they didn't want anything going up their nose. So this is what really drove our action point to strengthen self-collected sample types, which I'll talk to you more about in the next steps. So our path following this research included a successful co-application with FNHA for a BC Ministry of Health Innovation Grant. We are currently in the process of validating non-invasive sample types. So this includes saline gargle and oral nasal swabs for kids that are too young to reliably gargle. So we're currently validating that at the BC Children's Hospital. And the intent is to implement this in FNHA's community-based testing network following the validation. We also are working with the FNHA team to develop infographics and educational materials for testing and self-collection. And lastly, we are supporting potential expansion to other tests in the community. Thank you guys. Any questions?
Any questions from the audience? How did you select your communities?
Our communities weren't selected by us necessarily. It was just the communities that FNHA had implemented the community-based testing in. So their team did a lot of work into selecting which communities wanted the testing. It was all community driven was the goal. So it was only implemented if the community had interest in getting this testing, from what I know. But that was driven by FNHA during COVID.
This is maybe going beyond what you can comment on, but how do you know if FNHA selected these? Did they have any criteria for selection of communities?
I'm not sure about specifics. I'm very sure that they definitely did have a criteria, which most definitely included having the capacity for the testing. So having enough staff on to be running it. And they did a lot of their own evaluations and have been doing a lot of their own evaluations on how to make it easier to implement and to make sure it's successful in implementation as they continue forward. But I'm not sure about specific criteria when they were implementing.
And then it looks like Dr. Amy Klepetar has her hand up, or also our next presenter.
I just had a quick question for Hannah. I'm curious about the nurses. I've been to some of these communities and it's a lot of agency nurses or short-term temporary nurses. Did that contribute?
It did, most definitely. Some of the nurses that we interviewed were agency nurses, and we were specifically reaching out and contacting nurses that had been there and were trained for this. But that was absolutely a huge barrier for us, was that a lot of the nurses who had been trained and had experience with the device and had insight were either not working at the stations anymore, or in the beginning they hadn't been working at the stations enough to be trained, because the training takes a couple hours on its own, and then there's an in-person component. So whoever was there at the time they were implementing is really who got trained, agency or otherwise, but that definitely was something that was seen in our research. Any other questions? Great. I think that's all for me then. Thank you guys.
Hi there. Can you guys see my screen and my slides?
Yes.
Excellent. So hi, everyone. My name is Amy Klepitar. I'm a PhD student at UNBC in the School of Health Sciences, and I'm going to start my timer. I'm also an instructor. I'm a nurse and an instructor at UNBC's School of Nursing. Today, I'm wearing my student hat, though. I wanted to acknowledge the lands that I live on and I work on. So I straddle two communities of Smithers and Terrace in northwestern BC, but just wanted to acknowledge publicly that I'm here uninvited. I'm a settler, and I'm on my own journey to learn more about colonialization and the ongoing impacts, and to work towards reconciliation both in my professional life and my personal life. So today I want to talk about, I'm early in my PhD program, so I'm just getting started at planning out the next few years, but I wanted to talk about an initial stage that I'll be doing, and this is a literature review of some of the challenges and opportunities that exist to within the realm of environmental health research, but a lot of them are going to apply to anyone doing rural health research. And the background is something that we've already heard about today. I'm sure everyone on this webinar is well aware that there are ongoing and persistent health inequities for those who live in rural, remote, and Indigenous communities. And we have a wide range of contributing factors. They include historical and present-day colonial systems that determine control of Indigenous land. It includes political marginalization, a low critical population mass that exists for health and social services to be in all of these locations. And then also really relevant to environmental health is the likelihood of having resource-dependent communities. And where I live in the northern part of the province, we see that very often. We also know that environmental health risks are not distributed uniformly across populations, and those who do live in these resource-dependent communities often have the greatest exposures and the greatest risks, and coincidentally may have less accessible health care and health services to mitigate those risks or treat the health issues that arise as a result. And one thing, this is sort of the gap that I'm trying to explore, is that we don't have great methods to look at health impacts and health inequities within these populations for a variety of reasons, but we often resort to using the same methods to assess health and health risks in these populations that we do for larger urban and non-Indigenous populations. And sometimes this can create inaccuracies. It can ignore some critical, unique contextual factors. And I think you've probably all heard the phrase, if you've seen one small town, you've seen one small town. So those contextual factors really do play a role. And then the combination of these things leads to sometimes the avoidance of research even being done with these populations, or specific research that is done with these populations. We might take research done elsewhere and apply it to those populations. And so my objectives with this literature review were to describe the challenges that those who do study these types of issues and risks in small populations encounter, specifically those who are working with rural or remote areas and also Indigenous communities. And then based on those challenges and the literature, see what opportunities and approaches might be best practice for researchers who do engage in this type of work. And ultimately, my objective as a PhD student and as a researcher is to use those best findings in my subsequent work which I'll be looking at the health impacts of airshed pollution in the town of Kitimat, BC, which is on traditional Haisla territory here in the Northwest. And to just give you a brief idea of what is going on in Kitimat, there's a massive industrial development. There has been since its formation as a town, because it was a company town when the Aluminum Company of Canada established a large aluminum smelter there. And now that trend is increasing. There has been a pulp mill there, and now we have construction of the LNG Canada natural gas condensation terminal site and terminal. So a lot of industrial development, and at a very small town that is very close to those industrial sites. And so for this initial part, I have just done a narrative literature review, and I will be moving into doing a more formal scoping review in the coming months once I've moved through my proposal. But so it built on my qualifying exam process, where my supervisory committee recommended a set of readings, and I took those as the node, and then did forward and backward snowballing from there. And then did some database searches with Medline, Web of Science, and Google Scholar to find research articles, and also used Policy Commons because this area of research, there's a body of work that's in the traditional scientific research area, but then there's also a body of research that's done on the environmental assessment or health impact assessment processes. And so those are likely to be found in policy documents and reports and governmental documents. So I did try to reach out and look at those sources as well. And then I did a review of title and abstract and ended up with 50 sources for this initial less rigorous than my eventual literature review. And that was plenty to find lots of information. And I do think this is an area of a gap. I ended up with 50 sources. About half of them, or slightly more than half of them, did directly speak to the process of health impact assessment, environmental assessment, or some type of impact assessment. And a large majority of that, a little less than half of those 50% referred to working with Indigenous populations, and then the remainder mentioned Indigenous populations in the text somewhere. About a quarter of all of the sources I uncovered recommended specific statistical approaches, new methods or tools, or ways to better aggregate data. And then another quarter had recommendations on overall research design, how to better get at the approaches to assessing health or health risk in these populations. And almost every single author did outline challenges that they have encountered or others have encountered when looking at environmental health or assessing health risks in these smaller populations. And a definite smaller group offered ways to address those challenges. So it makes me think that lots of people do encounter the challenges, and while some do have opportunities to offer, not everyone knows how to best assess these health challenges in small populations. And so I'll just skip right to findings. And I will say that historically, assessments have been based on the physical aspects of health that we might think of immediately. They're easier to measure, and maybe not always the ones that are most informative or appropriate. So, for example, health indicators in a population, mortality rates, morbidity rates would be very often used, but they may not be the priorities that the communities have. And that speaks to the second challenge. We heard our keynote speaker speak about this a little bit, but the social impacts are really important to people, and how their lifestyle and their day-to-day life is impacted is very important to them. And not that mortality and morbidity is not, but there might not be a direct overlap with what we would traditionally think of as the important health indicators. We see that the governmental processes of health impact assessment and environmental assessment may ignore cumulative exposures that are faced. And that's mainly because policy doesn't always dictate that these processes have to include cumulative impacts. So you may have 2 or 3 projects that are ongoing that create environmental health risks to a population, but they're only mandated to speak to their own contribution to that. And when these build upon each other, they may have synergies that much more negatively impact a community's health than each individual would alone. And then there are historical and cultural contexts that may not be taken into account when these health impact assessments or environmental assessments are done. And overall, some authors note that there is a lot of weight given to the economic benefits of projects. So resource development projects bring a lot of money to communities. There's a lot of maybe economic benefit to the province or the region overall, whereas the negative impacts on local people may be diminished in the way that this is portrayed. And so that could lead to bias. And the last set that I had just uncovered here are probably things that anyone doing rural research has encountered at some point. So one is that there's not a lot of data. And we have a lot of examples where we have large national databases and rural communities are not represented, or specific rural communities are not included. And so I mentioned if you see one small town, you've seen one small town, but it's important that that the data that is used does represent the population that you're applying it to. What I'm seeing that will be a big barrier to my research is that we have low population numbers and rates are unstable and prone to high error. So if you see perhaps an increase in some diagnosis over time, is that just an aberration due to the very small numbers that you have? And you'll probably have a high error in your calculations simply because of the very, very small numbers. And that leads to sometimes data being aggregated over a large area or over many years. And sometimes that's appropriate and sometimes it's not appropriate. But some of the authors note that this is not done in a systematic way, and it's an easy answer to data that doesn't exist at numbers where you want it. So you'll just aggregate many communities or many years of data. And then the usual rural remote areas are hard to access, transportation and cost are issues, research supports and infrastructure might be lacking. And we all know that demographics, baseline health status, and behavioral risk factors are likely to be different in small towns, remote areas, Indigenous communities, and from one community to the next. And then the last set of findings is opportunities. So these are what can be done. And these first set are general recommendations. And a lot of these are very logical, but they may not be done, especially in the realm of the health impact assessment and environmental assessment. So incorporating community values and priorities rather than what is felt to be the priorities of the researchers or the experts. Holistic health impact assessment needs to be the norm. So not just a narrow definition of physical health, but lifestyle, social impacts, those types of things. Especially in Indigenous communities, integrate Indigenous ways of knowing traditional knowledge with the empirical science that is more often used. Collaboration and partnerships, which take time, should be developed, and if possible, research priorities developed with those who live in the areas. And cumulative impacts should be incorporated when at all possible. And this brings very much, it brings a lot of challenge to research because it's complex, it's messy, it takes a lot of time, it's hard to pull pieces apart. And I mentioned synergistic impacts, and absolutely this is a huge challenge. And then using analytical tools that communities have reviewed and have accepted and validated. And I see I just have a little bit more time left. And so I want to leave a little bit of time for questions, but specific methods and tools that others have used successfully when working with small populations include moving to either a qualitative, fully qualitative, or a multi-methods approach to examining these questions. Some of those qualitative methods that have been used successfully are ethnographic methods. So again, time consuming, but a good way to get a broad view of what health priorities are in the communities and what the lived experiences are from folks who live in small towns, rural towns, Indigenous communities, and what their life is like and how their health is impacted. Another design is case series or case study design. And not just using these, but I think more broadly, moving to an overall acceptance of these types of methods. I think things have changed drastically in the last 10 to 15 years as far as the acceptance of this, but we still don't see very much non-quantitative research being done in environmental health, and definitely not in the environmental assessment process. So an acceptability of that is necessary. And incorporating community-based participatory approaches throughout, and it can be used simply, at a basic level to improve recruitment, participation, and depth of contextual knowledge, or it can be used throughout. And some other specific tools, GIS and geostatistics, can be used to help smooth out variable rates that are a result from small population sizes. Small area population statistics techniques, and then if data is aggregated, it's done with community input to make sure it's a relevant aggregation of data. And then the last thing is that we have these large national databases that may not include the populations that we wish to assess health in. And so it might mean that data needs to be collected specifically in these communities rather than taking external data and applying it to these communities. Okay, and so that's all I have for you today. Maybe I will stop sharing my screen. Okay. I see that Dr. Woolard has put a comment. Not a question so much, but just a comment from you. Yes, thank you very much. Well, you'd be happy to know that your friend Margot Parks played a big role in me choosing this.
What countries did your studies come from that you examined? And what regions from those countries?
The majority were from North America, but there was a little node of a few studies from Mongolia and South America. A lot of studies that come out of some mining research done around mining, or health impact assessments done around mining.
Alrighty, thank you very much.
Hi, good morning. My name is Minnie. I'm a fourth-year medical student. Can everybody hear me okay?
I can hear you very well.
Okay. So I will share my screen. Okay. Can everybody see my slides okay?
Very well, thank you.
Okay. So I'll get started. So hi everybody, good morning. My name is Minnie. I'm a fourth-year medical student from UBC, and today we'll be talking about a research project that I've been working on this year, and I want to acknowledge that the work that we've been working on is situated in the city of Merritt, the traditional and ancestral and non-ceded territories of the Inga Kumama and the Silks people. So a little background of what is happening with this project. Vulnerability mapping has been quite popular over the years as climate change and its impacts are being felt throughout the globe. So the BC Ministry of Health has been working on a population attributes file project. And this is an example of what that project can look like. So the city of Vancouver has a heat vulnerability vulnerability map that you can access on the BC Vulnerability Map website. And so the objective is to map vulnerability to a certain environmental threat, for example, heat. This could be wildfire smoke, etc. But what we're interested in is to see if we can use something like the population attributes file to identify people who would benefit from direct outreach before and during climate emergencies. And then second of all, to look at whether this population attributes files can be useful to build a registry like that. And then we can actually test it in a community like Merritt, which is prone to climate extremes. So this is Dr. Sarah Henderson, the Scientific Director in BC Center for Disease Control, and Dr. David McVie. And these are just to show that this is not just a student project. There are people who know what they're doing who are on the project. And before we go into building the registry, I want to acknowledge the historical context of registries, data registries in Canada, because we have to remember that registries have not always had the best intentions, especially in Indigenous contexts where lists were created to take kids away to separate families. And so there has to be reciprocity and cultural safety in this, even if it's coming from a good place with the best intentions. And so that is, we want to acknowledge that. And something similar, well, actually, a registry for emergency use is not a new idea. So for example, earlier this year in the summer, Halifax is looking to create a voluntary vulnerable persons registry for emergency use. And this is based on the Sault Ste. Marie Vulnerable Persons Registry, which I will go into. So in Canada, there are a number of vulnerable persons registry. For example, in Nova Scotia, in Sault Ste. Marie, in Ontario, in Jasper, Alberta, there have been establishments of registries, and all of them are self-enrolled, and or healthcare providers can enroll their patients or clients, and the enrollment criteria kind of varies between different municipalities. And I looked at all of them and then compared, and I talked to the people who built the registries and try to see what their criteria are and what their exclusion. Well, a lot of them are not purposefully excluding people, they just don't collect that information. And the registries are quite small. And then interestingly, none of the registries have been validated. They're all anecdotal. And this works off a opt-in model. So it's voluntary. But as we could sort of see, a lot of the people who may require help may not have access to, may not be aware of the registry. So opt-in models may not be optimal. So what I did this past, for past summer was I went to Merritt and reached out to the Indigenous health directors from different bands, and I talked to assisted living facilities, talked to physicians, talked to the mayor in Merritt, and talked to responder services like the RCMP, police, and the ambulance, and city council too, because which I will go into quickly. Merritt has experienced some climate climate emergencies in 2021, from the wildfire smokes to the flood. So Merritt has about 7,100 people, and then in 2021 there was a big wildfire smoke from Lytton that went all the way to Merritt. And then so I wanted to show you pictures of these matchstick trees. These are trees that are dead from the wildfire smoke. And this is the part of the Nicola Valley, and you can see that the riverbed. So following the wildfire, there was a big flood in November that happened, which required the evacuation of the entire city of Merritt, all 7,100 people, because the flood flooded over the sewage treatment plant. So the water is not drinkable. So the entire community had to evacuate. And you can see that the flood at that time came all the way. So the force of Mother Nature is quite apparent in these pictures. And this was the highway in Spence's Bridge that will lead to Merritt. And because of the flood, that this area, a new highway had to be built. So because of the impacts of climate extremes that were felt in Merritt, that's why we chose Merritt as a place to see, to try to develop a registry like that. And we wanted to engage the community into this, into building this registry. And so this is from talking to the list of organizations and the people. This is what the city of Merritt felt like were people that needed more direct outreach and would benefit from outreach during and before emergencies. So for example, the elderly, people who don't drive, don't have vehicles, people with disabilities, mobility limitations, people who are worried about looting, no access to phones or computers, poverty, mental challenges, no fixed address, people who are on oxygen or any sort of timed medications, living in more remote areas, living near riverbanks, higher hills or sawmills, or having pets and livestock. So these are the factors that people have identified. And we taught a lot of the, we asked people in Merritt what they thought about a registry like this. And so the opportunities identified include that people feel that the registry will be helpful to bridge the communication gap between different organizations so that they can work together better during climate emergencies, and to identify people so that evacuations can happen in phases. So the individuals who need more help can be evacuated a little earlier because they may take longer to evacuate. And we heard loud and clear from the community that they don't just want a list of people. They want to know what services we can connect them to before and after the disaster, teach them about insurance policies, equip them so they're prepared. Because a lot of people are still recovering from the aftermath of the flood and the wildfires, still displaced from their homes, still cannot rebuild their homes because they didn't know about the insurance policies that would have helped them more. And then, using the registry as something that includes a transfer summary so that, for example, when people were transferred to Kamloops, they know what kind of support they need. They know that, okay, this person can't really see, so then they need larger prints, or they needed like more other, supports for their challenges. And then some of the challenges identified include people not having access to phones or computers, and all of the evacuations, including like if you wanted to get social supports, you needed a phone or a computer to input your information in, and that's not possible for a lot of the folks without phones. And there were a lot of mental health impacts of the climate emergencies. For example, the mayor says that if it rains for more than 2 or 3 days in a row, his office is flooded with phone calls of people who said, are we going to be okay? Are we going to have to evacuate? Because there's a lot of anxiety over that now. And a lot of questions. So for example, who would have access to a registry like that? How do we keep it up to date? How would the different groups and organizations coordinate to use such a registry? And then this presentation, because we haven't gotten to the point of, we haven't built the registry. But today I really wanted to gather input from different rural practitioners about your thoughts, and like if you think about your the community that you practice in, whether that's something that you think would benefit your community, and then what's your opinion on such a registry. So we need to evaluate how useful a registry like this can be. And as you can imagine, if we have a list of individuals, there will be significant privacy, confidentiality, and ethical considerations. And that's why we engaged in community engagement early on, to see if we can mitigate some of that earlier on. So evaluation ideas from Merritt include using the Health Connect registry for people to self-enroll, so still including some voluntary part, and then working with nonprofits who know their clients well to help them enroll. For example, when we talk to the shelter, they have a list of people they know that will need more help. And then also the paramedics, police, and fire departments said that they can refer people who they feel may benefit, because they see a lot of the very vulnerable populations who frequent their services. And then the Indigenous bands that we spoke to already know, because they know their community well, so they know that, oh, so-and-so is bedridden, and in the event of an emergency, we'll need to get them out first. So often they already know who they need to evacuate first. And so it would be, important to take that into consideration when we build the registry. So the next steps would be, we're still working with the Ministry of Health to generate the list using the Merit data, including, so we'll have access to health administrative data using like Panda. So there would be some factors that we can take from the health administrative data to predict a list of individuals, and we'll internally evaluate the list. And if that's successful, then we'll take the list to Merit and then externally evaluate it. And so that is where the project, it's still ongoing, but we thought that it would be interesting to present it to different rural communities and and basically you because you practice in a rural setting, and we want to know if this is something that maybe your community feels ready for or not ready for, and what your thoughts are. And so in March of 2024, hopefully by that time we'll have the registry pilot built, and then I'll be going back to Merit to validate the registry idea. And that's the mayor of Merit. And then so this is Alana and her mom who from the Cooks Ferry Indigenous band, and they were instrumental in this project because I wouldn't have been able to travel to all the different bands around the Nicola Valley and being introduced to the different Indigenous bands. So I want to acknowledge them and thank them for their support, and I'll take any questions.
Thank you so much. One thing with, I don't see any questions here. So one thing with registries is there's always motivated people who are happy to establish them, but they need to be, it's like a garden. They need to be maintained as well. The motivated people establish them, move on, and then information becomes out of date and degraded. Who maintains these things? Did that come up in your conversations?
Yeah, so this is it's a great question because it came up a lot when we talked to folks in Merit, and once it's built, so in the other municipalities, they actually have a dedicated team that, for example, sometimes it's run by a nonprofit, sometimes it's run by the municipality itself. They maintain the list, and because of the nature of other models that's opt-in, it's like a self-enrollment, then they'll reach out to the same people every year to check in to see that they're still on the list, and because people sometimes pass away and things like that. And then in our case, because we're actually using data to generate the list automatically using health administrative data, if we build an algorithm, not a list, then it will be automatically updated using vital statistics data, and so it will be updated automatically. So we're trying out a different method of generating the list. So instead of a complete self-enrollment, we're going to build an algorithm using data science and to see if we can generate an algorithm instead of a list. Does that make sense?
It does make sense. I won't even get into privacy and data retention aspects of that because that's far beyond the scope of this. But otherwise, thank you very much. That was very nicely done. Any other questions or comments? I'm scouring the chat here. Nothing much. I have to acknowledge a minor potential conflict of interest myself. I may actually be involved in the next project and not even know about it. But I'll turn the proceedings over to Graham Maynard Pearson.
Hi, thanks, Frank. Good morning, everyone. Let's share here. Okay, so yes, hi, my name is Graham Maynard Pearson. I'm a research assistant with UBC's Digital Emergency Medicine Unit, and I'm going to be talking today about a novel geospatial method for estimating costs that patients and families pay for both virtual and in-person care across BC. And so just a little bit of background on this. So since the escalation of the pandemic, we've seen many new virtual care services or virtual care options being like created and adopted and then since then expanded across BC. And there's also been research in the past about patient costs for in-person care, particularly one study from BC from the Centre for Rural Health Research, which aims to look at patient costs, particularly for those in rural areas. And this found that patients often pay a substantial amount out of their own pockets to access care. And there's kind of varying studies that focus on different types of costs that patients pay. And then our method aims to address the growing need for economic evaluations of both virtual and in-person care, particularly since these options are often being compared and evaluated against each other as potential options now. And so the economic component is becoming increasingly important. And our method aims to do this in an objective way where we can capture a complete picture of costs to patients and then use that to compare virtual and in-person care where applicable. And so we're going to spend a lot on the method because that is the core of the work here. So to do this, we've calculated costs for different categories, and these we've defined as unit costs. And these are calculated across 4 different service types. So there's ED visits, family medicine visits, hospitalizations, like admitted hospitalizations, and then virtual physician visits as well. And then in addition to the different service types, we also have cost categories for different age groups and different health authorities. And then specifically in the case of ED visits, we also categorize by the Canadian Triage Acuity Scale or CTAS levels. We categorize between the CTAS levels 1 to 3 and then 4 and 5 as well. And so this gets us to have a individual unit cost for each combo of service type, age group, and health authority. So we'll have a unit cost for Northern Health for the 15 to 64 age group. And then in the case of an ED visit, there's another category as well. And then once we have each of these costs, to actually calculate them, they're broken down into 3 sort of subunits. And those are lost productivity, informal caregiving, and out-of-pocket expenses. And so the sum of these make up the total unit cost for each category. And then we'll get into a little bit about what each of these are and how they're calculated. So lost productivity, this is essentially determining a valuation of the total time that's committed by a patient for a visit. So we calculate not just the time for the visit itself, but also any wait time or crucially travel time that's involved with attending the visit. And we sum this up to get a total time, and then we use average wage data to get a monetary value for this time. And then that cost is then the lost productivity subunit. Very similarly, for informal caregiving, we're determining the value of time for a caregiver. So same calculation method, including the travel, wait time, and visit duration, but this is from the perspective of a caregiver. Then the difference here is that we know that not all visits are attended with a caregiver, so we kind of prorate, if you will, for the attendance likelihood of a caregiver. So we assume 100% for 0 to 14 age group and then 50% attendance for other age groups. And then out-of-pocket expenses, this is kind of the most straightforward. These are the costs that are probably more often thought of as patient paid. So these are sort of direct travel costs like fuel or vehicle maintenance costs that are associated with attending the relevant visit. This could also include meal costs, parking, accommodation if relevant, or it's a little bit different in the case of virtual visits because of course there's no travel most of the time. So this may be like a data usage cost or internet access type of cost for virtual visits. And then so once again, we have then a total for each of these subunits, and then we add those together. That's the total unit cost. And really at the core of how we're calculating it is this geospatial component. And so we see a map here of BC. The red markers are the visit location. So we've used the nearest ED visit location. And then the blue dots are the center point of each community health service area, so CHSA. And this is how we're calculating the travel distances. So our method uses real road network data taken from OpenStreetMap to calculate the distance between the center point and the nearest ED location. So on the next slide, we'll see kind of after the method is applied, we see the different routes that are generated. And so that's what the lines are. That's going from so the starting point to the ED location. And these are color coded by distance in kilometers. And so we do see more kind of longer distances in the northern and more rural areas. And so once we have this, we have the travel distance, and then the method is also able to calculate the travel duration based on this road network data as well, using like speed limit information, things like that. So we have a distance and duration for each CHSA with this method, and then we aggregate it up to the health authority level, and we using like a weighted average based on the population of each CHSA. And then the travel distances inform the out-of-pocket cost calculations. That was like the fuel and the travel costs. And then the durations inform the other two subunits with primarily through the travel time. In terms of data collection, all data used is publicly available, which is kind of a key piece. And so data on wait times, visit duration is obtained from either peer-reviewed studies or companies that publish data for family physician wait times, and CIHI, which does that for hospitals. And then, as I mentioned, the geospatial kind of road network data comes from OpenStreetMap, and then we also use travel costs from CAA. But again, the main takeaway is that it's publicly available data and it's all kind of easily accessible. And then this is not meant to be viewed in entirety, but this is just an example of the kind of database that we generate from this. So this each kind of row represents one of these individual unit costs that I was mentioning. And so from this, we can just take away that we do see quite a range of different costs. So if the highlighted and circled row there for emergency in Northern Health, we can see up to $300 of patient paid costs. But it can range all the way down to about $30 for a family medicine visit in Vancouver Coastal. So those are obviously not like a direct comparison, but just to kind of show the range of costs that can be borne by patients for different services. And looking at sort of some of the overall results of this, this is looking at a single ED visit in the CTAS 4-5 category for age 15 to 64 patients. And we see sort of the geographic breakdown by health authority, and then with the individual subunit breakdown as well. So we see pretty clearly from this that Northern Health has the highest per visit costs, and then kind of ranges down to Vancouver Coastal with the lowest. But then also we see that virtual costs are substantially lower than any other of the in-person counterparts, primarily due to a lack of travel costs. And now we can look at a comparison also by service type. So this is again looking at 15 to 64 age group, but now we are comparing the emergency visits, family medicine visits, and virtual visits here. So we see again that the emergency are typically more expensive than family medicine, but both are also typically more expensive than virtual. And again, we also see that even for family medicine, the kind of geographic pattern holds with Northern Health having the highest costs. Additionally, we use the travel distance information to calculate greenhouse gas emissions to kind of get a environmental cost point of view as well. So we calculated CO2 equivalent emissions in kilograms, and then we used average fuel efficiency to turn this into like a cost type of number. And then again, we had this at the CHSA level. And as the CHSAs are categorized in a 1 through 7 scale for rural and urban, then we kind of aggregated this to rural urban to show kind of the average distance per visit and then the resulting costs, both in the actual emissions volume and the dollar value. One point is that the dollar value may not look significant at the per visit level, but if you imagine it aggregated over a whole population, this is every single visit is incurring that type of cost. And this is not even to the patient, right? This is on top of the travel costs the patients are paying. This is the actual dollar value of the carbon emission. So I think it's, a little bit important to just imagine it over a whole population. A couple limitations to acknowledge of the method are that we are using ED visit location. So if we knew the location of every single visit location for a family medicine appointment, this may include a give a more accurate result. But we did also test it with a list of this, and it's not that significantly different. And then since we use the center point of each CHSA, it's not necessarily representative of the actual route traveled by every patient within that CHSA, but the center point is used to give hopefully like a overall accurate average for everybody who lives in that area. And then we also assume that lost productivity only applies to working age populations and are thus equal to 0 for age groups other than that. Of course, the time of these folks in these age groups is valuable, and so it's likely an underestimate for those age groups. And so in summary, this method shows that substantial costs can be paid by patients for in-person visits in particular, and we're then able to support the conclusions of some previous research, like the study I mentioned in the intro, which finds that there are considerable costs, particularly in rural areas and particularly for travel-related reasons. But we're able to expand on this by providing a kind of objective method that can calculate these costs across a range of service types, across a range of regions, and is not dependent on like patient survey data or anything like that. And so in finding that these costs depend on where patients live, we can see that there's considerable like geographic variation across the province. And we think that because we're including costs that are frequently overlooked, such as travel costs, lost productivity, these are not costs that typically make it into patient estimates. And so we think that these are often of actually increased importance to patients in rural areas, because patients living in those areas are more likely to have larger travel costs and then thus larger travel time, and then kind of correspondingly more lost productivity as well. So we think that this method is particularly relevant for patients in rural areas, as well as people making decisions about service options in virtual areas in rural areas, because virtual care may provide additional benefit if the in-person costs are higher due to higher travel costs and such. And so these results can potentially be applied to new or existing virtual care to show economic benefit, either to compare existing services or when evaluating a potential new service. And some potential extensions would be to combine these unit costs with real resource utilization rates to determine like a real total cost for a particular service. And then we'd also like to create ways to allow for custom values to be used. So our results represent an average case, but we'd also like the method to be applied where you can implement your own travel time or your own wage or other parameters that are relevant to a specific case. And I'd just like to acknowledge all my team members at Digital Emergency Medicine, as well as all our partners who work on this with us, including our work with Heidi and RTVS, and that includes our RCCBC. So thank you for that, and I'll open it up for questions. Thanks so much.
Start off with a really good question. Dr. Klepetar, do you want to just state your question? I can read it out too.
No, it just took a second to unmute. Just where does the ED data come from? Because I know NACRS doesn't represent small EDs.
Yeah, so I think that that's a good point. I think that we are using just the ED data is coming from the CIHI reports for like ED wait times. And so, yeah, I do believe that not every single ED is included in that. So I think it would be just based on the ones that are included in the CIHI ED kind of annual reports.
Thanks so much. And thanks for including the CO2 emissions. That's a nice added view.
Yeah, thank you.
I'm not sure if this is this is from Elizabeth Stacy, works with Emergency Care BC. Elizabeth, do you want to mention your question, or do you want me to read it out? I can read it. Thank you for this great and comprehensive presentation, Graham. Can you discuss the implications of these findings? We would expect that virtual care is less financial burden on patients. The virtual care can't provide all the types of care patients may need. It would be great to expand virtual care, of course, but what other implications might this research have? And this wins the prize for the most open-ended question of the day.
Yeah, thanks so much. Yeah, this is a great question. And yes, I do agree. I think it is important to note that virtual care can't replace all types of patient care. Like, I think one example from my presentation is that CTAS 1 to 3 level is likely not to be replaced by virtual appointments. And so I think, yeah, I mean, I think it does, we do show that virtual care is less financial burden. And so I think that one of the implications would be that for the types of care that can be potentially replaced by virtual care, like some family medicine visits or some, kind of less acute, lower acuity type of ED visits, if we're able to show that virtual care is less financial burden, and if that spurs on expansion of virtual care that can then take a higher volume of those visits, then it potentially leaves more resources and time available at the in-person locations to address the types of cases that can only ever be addressed as an in person, as opposed to those individuals working needing to address all cases. Also, I think that another implication is that I think, like a primary takeaway is the comparison between virtual and in-person care, but I don't think the method can have implication beyond that as well. I think that even just evaluating in-person care options, even if there is no virtual alternative, I think that the method has value in just kind of looking at what patients are paying, and potentially there can be, changes or expansions to a in-person service to reduce patient costs, even if there's not a virtual option. Maybe, knowing how much patients are paying for a particular in-person service would be useful in kind of adjusting that to lower the burden.
Excellent. Thank you very much. This is very nicely done. We have
Do we have
2 minutes.
time for one more question?
We have one more question, but that will pretty much, I believe, obliterate the break that we had planned. But Dr. Cressman, go ahead, please.
Okay, I'll just leave it as a quick comment to add on to the last question that we have a framework called financial protection. It's a WHO recognized metric which calculates the percentage of a patient's income versus what their medical expenses are. And if they cross a threshold, we can say that they're at risk of adverse health outcomes that are related to their financial expenditure for seeking help. So there's an equity framework that we can do as well, and we're really excited with this evidence to inform that in BC. Done. Thank you.
Thank you, Sonia.
I put in one comment since we don't get much of a break anyway. I noticed you showed all the bars of the costs. There have to be some confidence intervals around that, to say the least. I'm sure that at the extreme margins that the costs are actually much, much higher for some people. Probably the most local.
Definitely, yeah. Absolutely. Yeah. I think that that's another point to note, is that this does represent sort of an average case. And that's why I think that the customization option is particularly relevant, is because, yes, there would be, particularly in, rural areas, for example, there would be patients with significantly higher travel costs, which would result in much higher costs overall. So I think that kind of having that in tandem, where you can use the same method but customize your own values, would be quite valuable, especially for that case.
Excellent. Thank you so much. Well,
thank you.
Stretching is going to have to be in place right now. We're going to, in order to stay on schedule, we'll go with Dr. Allison James.
Thank you very much. And there's no doctor in my name. I'm just going to share my screen. Can everybody see my screen? No. Can everybody
just do the full slideshow? Just to enlarge it.
There we go. Are we good now?
It's not the full slideshow. It's good enough that we can see your slides, but it's just not the slideshow.
It's the 2-screen business.
Mm-hmm. We can see it well enough for any kind of educational or presenting value. So perfect is the enemy of good here.
Okay, let's get started then. Good morning, everyone. I'm Allison James, and I'm going to be presenting our study called Emergency Medical Transport in British Columbia, Narrative Stories from Providers, Decision Makers, and Patients in Rural, Remote, and First Nations Communities. And I'd like to start off with the land acknowledgement. I'm joining you today from the unceded and traditional lands of the Comox First Nation. And this is a picture from Comox, and really fortunate to be a settler here and to live, work, and play on these lands. In terms of a background, we know that emergency medical transport continues to be an issue for rural and remote British Columbia. And transport is a really complex phenomenon, and it's impacted by many different factors, everything from patients' conditions, services available in the community, the expansive geography that we have in BC, weather conditions, and what's available from air and ground transportation in terms of resources and staff. And overall, there's been very little data on emergency medical transport in rural communities. And so the Rural Coordination Center, and I work with RCCBC, decided to take on this study to better understand the experiences of physicians, nurses, health administrators, patients, and their families related to emergency medical transport in BC. So in terms of methodology, we did one-to-one interviews to gather experiences. They were semi-structured interviews to investigate the barriers and facilitators, and we used an appreciative inquiry approach. Overall, we did 31 interviews with 16 providers, 6 patients, and 9 decision makers across BC. And it was a fairly good distribution across the entire province. And we coded and analyzed for common themes using a qualitative descriptive approach. So I'm going to start off with a patient's story. And so I'll read this out to you. Well, basically, I would say that 90% of the whole thing went well. Fortunately, I was home and I collapsed and hit the floor. My wife called 911. They started working on me in the ER. I arrested in the ER. In fact, I arrested twice. I arrived at the hospital about 1:30, and at about 6:30, they were prepping to take me to the airport. They loaded me on the plane and assured me that the crash cart was ready. That was my biggest fear. I didn't want to arrest on the plane. The cardiologist was there waiting for me and explained what was going to happen next. I ended up with 3 stents. It happened 7 weeks ago. So I talked to this man 7 weeks after his MI and his arrests. He was a 76-year-old man, and he lives in a small community, and it's not easy transport. What this quote doesn't explain is the fact that he went on the plane alone, and he didn't have any contact with his wife until after he came out of the recovery room at 10 p.m. So when we look at what does successful emergency transport in rural, remote, and First Nations communities looks like, we came across 4 themes in our data. The first came down to really successful transport is related to the right care at the right time in the right place. And this is a familiar quote to many people. So the patient receives the care that's needed. They're transferred as quickly possible based on the patient's acuities and needs, and that they receive the care in the right place, meaning that definitive care can be provided, and it's geographically close to the family. When we look at this in a little bit more detail, what it comes down to is availability and timeliness. So what we heard again and again in the data was that the stars align, that the transport is available. So the time of the day matters, the time of the week matters, and what the weather conditions matter, and that there were appropriate staff and resources available. So as a quote, what makes it go well? We didn't hear this once, it was multiple times. It was, what makes it go well is Monday to Friday, 7 to 3. The second theme that really came through was about collaboration and communication, so teamwork. And I'm not going to go through, for the interest of time, every piece of this, but really what success looks like is that there's regular updates and flexibility in decisions that support patients. So that means that if 2 patients need to be transported at the same time and there's availability to do that, that is what happens. that things like a conference call where multiple partners that are making decisions about what to do with a patient are on the call at the same time. You can imagine that the successes and the challenges are sometimes a little bit of a flip of each other. But some of the challenges that we heard with respect to this theme was really things like the lack of ability to delegate to team members. So this is about a physician having to be on the call with transport, providing sometimes very administrative and basic information and not being at the bedside of the patient. And that stress and that challenge that it creates for providers in small areas. And then gaps in communication. That's everything from with the patient and with the providers as well. The third theme that really came through was what we talked about as the rural reality. And this is talking about the resources that are available in a community, as well as the resourcefulness of the community. And so we heard again and again in our data that rural communities are unique, their situations are unique, they're resilient, and they're resourceful. So for one quote, people are more than willing to pitch in, do what they need to. It's a real team effort. The flip side of the rural reality is that many times rural patients are really in precarious situations, depending on the acuity of the emergency transport that they're facing and depending on the resources that are available. And those resources really vary by community. There's at times a lack of an appreciation of the rural situations, and rural providers are often left with making really difficult decisions. So as a quote, we'll just make a run for it. I've done it myself many times. We had a child a couple of years ago and we had no response from the ambulance to come. So we had to transport the child in the back of a private vehicle. As you can imagine, that these situations have impacts on the individual. And so the fourth theme that really came through the data was really about the individual impacts and the distress that's created from that. So the stress and the psychological distress of waiting for transport for both patients, the families, and providers. There's the moral distress of not being able to provide the standard of care. It happens a lot. And it's frequent cause of moral distress within my group because we're not providing the care you know that these patients would be getting if they were in the city. And then was an exhaustion that was observed in these interviews from many of the providers. And that exhaustion was resulting from that straddling of the line between patient advocacy to get the patient the care that they needed and the feelings of helplessness at times when things are really not within your own control. You can imagine that these stressful situations do have impacts on providers, and we heard the impacts on providers, that it was seared in their memory, that these situations can have a real impact of retention in rural communities. When we looked at the data, we asked questions about recommendations, and I'm not going to go into all of the recommendations that came from this data. You can imagine it was a rich data source, but really we were able to use the quintuple aim, which is a common framework for health care improvement, where we look at equity and accessibility, resources, and all these different factors that can be used for healthcare improvement. So I'll give you a sample from what we heard from the data. So with regards to equity and accessibility, really we heard providers and patients really advocate for a 24-hour, seven day a week service delivery model for emergency transport. That there was a feeling that there should be defined minimums and maximum transport windows by acuity level. So it shouldn't be 2 days to get to a location if it's a certain level of acuity. In terms of resources, some of the recommendations that we heard was enhanced physical infrastructure in the communities. So helipads that are big enough to accommodate the helicopters that arrive. Airport infrastructure, which includes lights so that services can be obtained in after hour or in dark hours. road signage to some First Nations communities where ambulances have a hard time navigating and finding First Nations communities at times because of lack of road signage. In terms of patient experience, we heard loud and clear that a really enhanced communication to patients and family members, consideration of the closest appropriate site. So we heard definitely in certain areas of the province, being transferred to a place like Calgary would have been a lot more beneficial than to Vancouver. And then also a strong support for culturally safe care. With respect to the workforce experience, we heard, you know, several, there was a lot within this. Support more BCEHS staff in rural remote, including advanced care paramedics. And we've just heard a recent announcement where we are seeing some of those changes already. With respect to communication and collaboration, support the ability for providers to delegate PT to the transfer calls to staff, and to expand transfer algorithms to include local input, whether, you know, another location, if one location is fogged in, etc. So in conclusion, because I think we're getting to time, you know, this qualitative research study really highlights the factors for successful transport and opportunities for improvement. And one of the strengths of this is that we have a diverse group in terms of age and type of participant and the region of the province, but not all people that are implicated in this type of research are seen in it. And our next step is to really create some knowledge translation products for policymakers, decision makers, and academics. And I'll leave with that there is no easy solutions when it comes to emergency transport, and it will take partnership to move this needle forward. So thank you for your time. Thanks to all of our participants in our study, and thanks to all the healthcare workers who provide care in rural, remote, and First Nations communities. And also like to acknowledge the rural patients who make this work matter. So if you have any questions, I'm open.
So Allison, hi, Allison. So first things first, Dr. Schumacher just had to step away to conduct some patient safety rounds. And so I'm filling in for him. Allison, Allison and I are colleagues at the Rural Coordination Center of BC. And this is actually the first I've heard about this research. This is the first time that I've seen it presented. So fascinating stuff. So we'll open it up for questions. Dr. Cressman mentions in the chat that she really appreciates this work and the team, and it's been echoed by others, other panelists. So this is near to my heart. Dr. Watchhorn from Golden and District Hospital last year at this same BC Rural Health Research Exchange presented on his patient-controlled analgesia work in emergency transfers. And that speaks to your point about the resiliency and innovative sense that a lot of these rural providers have to improve the transport of their patients and ultimately the care. I'm wondering if this touches on returning from emergency. So often patients are brought to emergency, but then they have to find their own way back. And I'm just wondering if you can comment on that, Allison.
Absolutely, Jason. You know, it was a huge piece from providers and from patients and from decision makers of the challenge of you end up being in another location and there is no support whatsoever to bring people back. And so it really impacts whether a provider is willing to get in the back of an ambulance. It's a huge source of stress that we heard from participants. And you know, there's some recommendations that I didn't go into, but just looking at whether there could be some way to have supports so that either it's a provider or a patient, knows what to do next. Absolutely, it was clear in the data.
Great, thanks, Allison. I'll ask another question. Just going back to one of our previous presentations by Graham there, where he contextualized the qualitative data that was currently in existence with quantitative data. I'm wondering if you and your team have asked yourselves, how could we quantify some of this work to complement the qualitative work that's already ongoing?
Another excellent question, Jason, because oftentimes we do have quantitative data on this. You know, there's emergency medical transport stuff that comes out from, you know, different sources, but the rural piece sometimes gets missed, or it gets rolled within the larger data, where we know that, you know, our majority of our populations live, you know, 80% live within kind of the urban areas, and that it's that 20% that don't get really, their statistics kind of get drawn into that larger population. So I think having this type of data, and that really looking at the impacts, is really important, because we can look at wait times, but sometimes those wait times don't really account for all of the factors that kind of go in behind the scenes. That, you know, we asked one of the questions of what would you want to measure, and oftentimes it was from the time that I called to when the patient was picked up, because sometimes those statistics get a little bit skewed.
Great, Allison, thanks very much for that presentation.
Thank you.
We'll now switch to our next presentation by Ashmita Ray from UBC, exploring what we're talking about this topic, exploring rural emergency health service innovations in BC. Ashmita, I'll turn it to you.
Thank you, Jason. Let me share my screen here. Yes, perfect. Hi, everyone. My name is Ashmita. I'm a PhD student and a project coordinator from the School of Nursing at the University of British Columbia. And I'm here to present you the preliminary findings of the research that we conducted on emergency health services in innovation in BC. And I'm presenting on behalf of the whole team, who come from multiple disciplines. And before I begin, I would like to acknowledge that I'm joining from the ancestral, unceded, and traditional territories of the Sault Nation, Okanagan. And this research and the work of research team members took place near and far, and I would like to acknowledge and appreciate the traditional caretakers of those lands. Starting with the background of the project, and around 20% of the population in BC lives in rural and remote communities, and they face more diverse and unique challenges in healthcare delivery, particularly emergency health services. And the government of BC has made tremendous efforts to strengthen the rural and remote emergency healthcare system by increasing the budget in transfer services, and also implementing innovations such as real-time virtual support to aid patients and healthcare providers through virtual emergency health services. However, there is a limited information on these innovations, and the main objectives of this study are to explore and understand how these innovations came to be and how they evolved over time, and to develop recommendations for policymakers and decision makers to improve innovative emergency health services in rural settings. And we used a case study method with a focus on narrative methodology, where we collected stories from the participants of their experiences with rural health, emergency health services. And we recruited 3 case studies, 2 in northern BC and 1 in interior BC, and all of the case studies were rural and remote communities. And we had 2 phases in our study. In phase 1, we collected descriptive information of the communities from the internet or their community websites, and historical and cultural information, and along with the types of services they had. And in phase 2, we conducted interviews with managers, health providers, admin staffs, and also a focus group with patients and community members. And we also are in the process of collecting administrative aggregate data from digital services and BC EHS, BC Emergency Health Services, and Trauma Services BC. And we will be conducting a research process survey to gather feedback from the participants on the research process. And so far we have completed data collection and most of the data collection and analysis for case 1 and case 2. And we're still in the process of collecting and analyzing data for case 3. And the innovations that were in place were real-time virtual support. They were using translation apps, electronic triage and transfer systems, Lucas system for giving CPR, and innovative methods for home care services and virtual care. The findings suggested that overall these innovations increased patient experiences and health provider experiences with a better population outcomes. And for patient experience, it had increased access to emergency health services with the reduction in transfers, unnecessary or avoidable transfers out of the community, with fewer wait times, and the innovations provided continuity of care to the community members, and which had increased their quality of life. For health providers, the relationships developed between the RTVS and rural providers improved enhanced learning, and provided additional physician support, which had a positive impact on the retention and recruitment of the health providers, as they had a higher job satisfaction with decreased stress, and it had also increased their self-confidence. And overall, it had better health outcomes for both patients and community members. The barriers, there were some of the barriers to innovations, and some of which are limited resources such as funding and communication and technology infrastructures, like Alison mentioned in her presentation. And also there were barriers to innovations for mental health services and supports. Some of the other barriers were cross-jurisdictional policies and bureaucratic administrative policies for transferring the patients out of the communities, and also staff. There was a shortage of staff. During the interviews and focus group, we also gathered some of the recommendations, and we had common themes in the recommendations between case 1 and case 2, as both the cases recommended in expanding RTVS support and services to other areas in the hospital or community health centers. And along with the innovations, there was a need to increase staffing, such as family physicians and nurses, to reduce the workload. And there was a need for proactive planning and in collaboration with community organizations as their aging population was increasing. And they recommended advancing communication and technology to improve logistical efficiency and also improve the communication between the providers and providers involved in patient transfer. And some of the other recommendations were exploring alignments of health policies between different territorial or provincial governments at a policy or macro level, and also exploring administrative policy for emergency patient transfer and reducing those bureaucratic inefficiencies. And one of the important recommendations was also increasing funding allocations for infrastructures and associated costs with the transfers. And they also recommended to increase access and resource to and for mental health services and support, and increasing awareness of innovations. And these programs were also recommended to better utilize the innovative methods that exist in the hospitals or community health centers. The findings of the study provide an opportunity to learn about new innovations in rural communities and has the potential to scale and spread to different rural communities in BC and as well as urban settings. And the barriers identified in the study could be addressed and to facilitate equitable access to emergency healthcare for community members in rural BC. And it can help policymakers and decision makers and providers and patients and communities to understand the structure, functioning and barriers and facilitators of innovative methods of care in rural emergency health services. And the findings have the potential to guide future policy decisions and practices to achieve the quadruple aim, which is to improve patient and providers' experience, population health, and with a sustainable cost, and also improve equity in health. And the findings can be a foundation for future rural health and equity research projects. So our next step is to continue collecting data and analyzing the data for case 3. And we are, as I mentioned before, we're in the process of collecting quantitative data from administrative data from BC Trauma Services and Emergency Health Services and health authorities, which we will be integrating in the final reports. And we will be conducting an in-depth cross-case analysis between these 3 case studies, and we will share it back with the community via dialogue to share the final reports. And the final reports will also be shared with the participants, knowledge users, and other interested individuals. And we will develop lay summaries, infographics, and manuscripts for publications and presentations for knowledge translation activities. That was the end of the presentation. Please let me know if you have any questions. Thank you.
Thanks for that presentation, Ashmita. Really appreciated it. We'll take questions as usual in the chat box. Feel free to add them there. I'm curious about the kind of sharing and scaling of some innovations. As we heard from, I believe, Amy earlier in her presentation, you've seen one small rural community. You've only seen one small rural community, and so there's a bunch of contextual factors and differences that a community has that may require that an innovation that works in one community be adjusted. And I'm just wondering if you can comment on the sharing of innovations from one community to another across BC or across the country. Just what has to go into what would facilitate, or maybe even what are the barriers to making innovations work for other communities where it already works for one?
Thank you. That's a great question. One of the reasons health providers wanted to participate in this study was to understand what innovations are being developed and used in other communities as well. And so we will be compiling the data and all the cases data into one final report, and hopefully we can share it with the communities. And yeah, the barriers, I think the major barriers to the innovation would be the cross-provincial or cross-jurisdictional policies that they have in place for different provinces. And for example, the RTVS physician's report was not accepted, is not being accepted in a different province because they have their own policies. So even if it works for the community, it may not work for the cross-provincial situations.
Excellent, thank you. We have one other question. I'm just going to add Dr. Woollard here to ask his question.
Well, thank you
Hi.
very much. Ashmita, this is wonderful, and what a lovely succinct presentation. But it was occurring to me is any observations you have about how the cohesion of the professionals, the community, etc., was enhanced just by participating in the study. You know, the Hawthorne effect, that study changes things. And I just wondered if you had any observations as you looked even at the first two case studies.
So with regards to innovation, sorry, could you clarify that? Because
Yeah,
I'm not aware of the Hawthorne effect, sorry.
Yeah, sorry, Hawthorne effect was a concept from the 30s, where when you studied something, it changed it by virtue of participating in study. And so I just wondered if you had observed something, because this is at a close enough scale that I think someone as insightful as you are could kind of look around and say, wow, these people never met until we got them together for the study. Those kinds of things, because I think it's a potential impact of rural research, quite independent of what questions you're asking. The fact that you're asking questions will often bring a community together in a different way. And knowing how observant you are, I just wondered what you thought about or had observed.
Yes, thank you. So when we connected with the communities, they already had a beautiful relationship with each other. For case one, it's a small community, so everybody knew everybody. So, but for case two, I did observe that people were coming together, and they were very happy that their experiences they were not the only one experiencing those things with barriers that they had experienced. So they could relate to each other. And for case two, because it was a little bigger community than case one. Yeah. Awesome, thank you.
Great, thanks, Ashmita. Really appreciated that as well. We're going to transition. When we build the program for the BC Rural Health Research Exchange, we look for good segues and nice transitions, and this would be a perfect one. This is Sandy Lee from the UBC Faculty of Medicine talking about the drone transport initiative.
Hi, everybody. My name is Sandy Lee. I'm the Senior Project Manager with the Faculty of Medicine. So yeah, I really appreciate all the presentation that we had. I think it kind of sets the stage for a project like the one that I'm about to discuss. As part of the Faculty of Medicine, we co-created a project with the Village of Fraser Lake and the Schlatten First Nation to operate a drone project over COVID. And so I want to take a moment to just appreciate Schlatten and Notley-Wooten First Nations for allowing us to plan and operate the drone project on their territories. I also am calling in from Vancouver, which is the traditional and unceded territories of the Coast Salish peoples of Squamish, Musqueam and Tsleil-Waututh nations. I've been growing up here all my life and has been quite grateful to live in an urban location, and working on a rural project allowed me to really examine what gaps there are and what opportunities there are to co-create this solution. So to set the stage, what the drone project's purpose really was to really do a feasibility project to explore what are the opportunities of implementing a drone project. How can we complement transportation with existing health services? So knowing that there's increase in virtual healthcare, can we utilize drones to transport laboratory specimens, diagnostic tests, medication, so then patient journey could be closed and could be accessed closer to home. And so that's really the purpose of what we're doing here, and identifying who the key stakeholders are to execute this work. So we know that technology has been effective in many other countries, but what really makes technology be successful requires the right people on the project. And so the first phase of the project is to identify and work with the right people and build up the project from there. So before I go too far, I want to take a moment to just share a video. We don't have our community members here, and so I feel like it's important for us to just share the community perspective before I go into the rest of the presentation. So I hope the audio works here. Yeah. We started having it being a part of the community, having that medical device bring them their prescription. Drone Transport Initiative is really a partnership project that embeds drone technology into the healthcare system. In remote communities, the roads are not paved. There's hardly any traffic going in and out. And so a drone would, oh God, that would help so many people. Now I don't have to worry about getting my medicine. Now it comes to me. The drone and the telehealth help have community members stay at home. And that's a big thing. It provides a service where they can come to a health center that they understand. Ideal project that we use in the town. We have also had a Davies of the drone contest, and the drone is supposed to identify. One other thing this project brought to the community was sense of pride of being the first. First Nation communities in general are not very high on the list when it comes to medical technology. My hope is that we are the launching pad going forward, and that we are kind of the main drone airport to fly other First Nations with our area. There's so much more that we have with bringing this to do technology. They can really they don't have to worry about their medication, or if something happens, they need the drone, it needs to be right there. It's really awesome that, you know, this can get out to all different people. Right. I hope people were able to hear the audio. If not, I'm happy to share the video afterwards. Yeah, so in terms of our project, just to provide a bit of an overview, this project was not a research project. It was executed as a quality improvement, and so we're fully funded by donors, and we were just looking at building up what it would look like to expand a program like this. And so this communities that we were working with were Tsleil-Waututh First Nation in the village of Fraser Lake, and this is Flatco. This is Fraser Lake. Flatco's actually not too remote compared to some of the very remote communities like Takla Landing. So Stella is still along a major highway, Highway 16, which is also commonly known as the Highway of Tears. The population sizes are relatively small, about 200 people live on reserve. Fraser Lake is about 1,000 people. Most community members access their some of the primary care services in community. And so SLACO has a health center that is located there. There is also a physician that comes in on a weekly basis and virtual physician services available. Community members typically go to Fraser Lake to access any blood work, testing, and also their local pharmacy is also located there. And so the purpose of why we selected these two communities is that if we weren't able to deliver the medical supplies, it also allows us the opportunity to drive the supplies to the community so it doesn't compromise any patient care. So as I mentioned, we were really focused on co-creating the solution with the community. And I think one of the beauty of this project is that we were working in a university context. And so it opens up the opportunity for us to not only just work on a health solution, but also examine what does it mean to engage a community? What does it mean to build relationship with the community? And so as a cornerstone of our project, the partnership with the nation was so critical to the operation and implementation of this work. Without a strong relationship with the nation that was already established by Dr. John Polovich, it's really hard to imagine how we were able to execute this project given the timeline we had. And so some of the key values that we embodied in our project was really focused on ensuring that it's community-driven and nation-based. And as some of the other presenters had mentioned, every community is unique in their own ways. And so having that as a foundation established that we're able to hear from communities what their needs are and find ways of responding to that. We also discussed with the nations around like what are their decision-making pathway, how do they oversee kind of the data and the storytelling and the outcomes that we share with the public in knowledge translation. Other things that we examined was like, how do we build local capacity? That meant we trained local staff, we hired local staff, but that also meant we did a lot of community engagement with the youth. And so we worked very closely with the schools to build youth interest in science, technology, engineering, and mathematics. And so as part of the university, we're able to engage in those activities as well. And then some of the project outcomes would be improving health services and access. So sharing a bit about the project itself. So we received majority of our funding through TD Ready Challenge. And so we received the funding in March of 2021. I was hired in May of 2021, and we were asked to execute the project by the fall. And so we implemented the project in October 2021 to October 2022. It was a 12-month project. Over the 4 seasons, we wanted to collect information around climate and weather and how that impacts the drone operation through time. And so this really is one of the first drone projects that has executed over such a long duration. Instead of just looking at proof of concept of whether the drone can fly from point A to point B, we're really looking also into like, what does it mean to work with the community? How do we integrate the service into local health services? The change management of adoption of technology. And so those are like more in-depth questions that we're trying to answer through a longer term implementation of this work. So over the course of the 12 months, we completed over 1,200 flights. We were able to deliver medication working with the College of Pharmacists of BC to materialize this work. We also worked with the College of Physicians and Surgeons to develop processes on delivering medical laboratory specimens. We weren't able to implement it within our first phase, just given the certain delays in some of the progress. And so it was a more of an iterative process where we were able to proceed with some of the cargoes that we were able to deliver. And so I would want to highlight that a lot of this work was not possible without the partnership we established. So as mentioned before, the nations kind of defined what problems we're trying to solve, what needs they are having, and the partnerships we have with the health system really help build the capacity for us to deliver what the communities had identified as a need. And so we also partnered with Carissa County Family Services, First Nations Health Authority, RCCBC, the local pharmacy. Northern Health was part of some of the laboratory work. And so all of this is a partnership project that made this a reality. So just to go over some of the findings that we had, as part of our project, even though we weren't exactly doing a research project, we still executed a number of evaluation to examine the partnership, to examine how we can improve the work in the future phases, and also share the findings. And so we executed some surveys at community events, and then we also executed a number of interviews with community members as well as people involved in the project to hear back on what their feedback was around the project. So in the table here, it's just highlighting some of the key community member perception of the project. So we engaged community members at events, and so they were able to provide the feedback around their thoughts of the project. Majority of people were aware of our drone project. Many believe that drones can improve health access. And a majority of community members were enthusiastic of potentially continuing this project in the community again. Some things that we want to also hear from community was whether there was any impact of this project in a negative way. And so some things that we heard were concerns in the beginning of the project was noise and operation having nuisance in the community. And so from what we've seen in this table, we didn't really see any major concerns around the actual noise impact in the community. And so it's a very encouraging outcome that we've heard. Other more qualitative work was, in my opinion, very helpful in learning from what we've executing. And so what we really heard was one of the main theme was a partnership. And so, we received the funding at a very short timeline. We were asked to execute the project under a very short timeline. And if we weren't able to have Dr. John Polovich and Dr. Tara Aldred, who are already practicing physicians in this region and having all these relationships in place, I really don't think their project was able to be executed in the timeline that we're asked to do. And so the partnership piece is such a critical component to the work in building the trust in co-creating the work. We also use the data of the drone over the course of the 12 months to build longitudinal data to create a predictive model in informing what future drone project implementation will look like. So in the future, we're looking into our next stage. And so we're in the current process of planning for phase 2. And so phase 2 will be a 3-year project where we're able to continue the work in the Fraser Lake region that we have already done, but expanding it to additional First Nations community to do a network delivery. And then we're also now partnering with Prince George Airport, and then we will be piloting some longer range drones that are enabled by new drone regulations that are going to be announced in the summer of 2024. Thank you so much for this opportunity to share our project, and happy to answer any questions.
Why was the site selected?
Yeah, so I would say the selection of the sites was done more from a partnership perspective. And so this was initially a concept that kind of came up. The project sponsors that we work with already had these pre-established relationship. And then it's also the fact that Slackle First Nation is a very high capacity nation, and so it's a good location for us to establish an innovation project where they have the right leadership from a political perspective. The chief was very on board with the work. They had strong like leadership in the health services, like strong project management capacity. And so it makes it easier for us to implement this work. And then once we're able to develop an initial model, we can then at a later time scale it up to other locations.
Thank you. Before I turn the proceedings entirely over to Dr. Cressman, both with a question and then her presentation, comment from Dr. Woolard. The integration of relationship building and technology introduction is itself a profound finding and worthy of being fed up the food chain of tech diffusion. So thank you for that insight. Dr. Cressman.
Hi, thank you. I feel like there needs to be a virtual round of applause for you. There was this quiet moment where in my mind, there we go, I see some hands up. That's amazing work. I wanted to ask a quick question about your survey results that you presented. There was just the question on the right is, would you feel that the noise was too much from the drone? And something like 60% of them were like, strongly disagree or disagree. And I felt that response was quite vested in like it's saying something. And then the question before that asked, would you like to participate in this again? And while most people said yes, of course, there's still 20% that disagreed and said no. And I'm just wondering, you know, if we could unpack that, would it be because they really wanted to go forward? Like they were overwhelmingly agreeable to the technology. It could obviously make things easier for the day-to-day living. Why wouldn't they want to do it again? Are they done with the research and like, all right, that's enough evidence?
Yeah, well, I think like as I mentioned, like the location was not too far in terms of distance. So Sklako is actually not the most remote communities. Like a big part of this work is that the nation wanted to contribute to supporting even more remote communities like Capitol Landing, which is a 5-hour down a logging road north of where they're located. And so I would say the material impact on community members in this specific example is actually not that impactful compared to what we can do in the future. And so I can see how like there is an element where there's a bit of hesitation with, okay, we're investing into this time and energy in doing this work, but it might not necessarily be felt that the material impact is as significant as it could be once it's scalable to a larger context.
Amazing, very telling. Thank you.
Thanks.
Are there any other questions for Sandy? Great. Okay. Well, I think I'm up next, so I'll just share my screen. Can you see front slide?
You can just hit slideshow.
Mm-hmm. There we go.
There you go.
Looking good. All right. Okay. Hi. Thank you so much for inviting me to this wonderful gathering of researchers. My name is Sonia Cressman. I'm an evaluation lead at UBC Digital Emergency Medicine and a health services researcher with a background in health economics and equity impact analysis. I represent a fabulous team of colleagues at UBC Digital Emergency Medicine, as well as colleagues that are represented by many of these organizations on the left here in the partnerships that bring together the learning health system surrounding our real-time virtual support, or our RTVS network of virtual physician services. Sorry, just learning how to switch slides here. The objective of my 10 minutes today are to share the RTVS Learning Health System objectives and some performance indicators, review 3 DKP cycles, that's code word for data, knowledge, performance. It's an LHS thing, I'll unpack that in a minute, and talk about how research is embedded within the health system through this learning health system structure. And hopefully be able to support research at RCCBC through the wonderful connections that I share within the learning health system, the RTVS learning health system. So I'm going to talk about what a learning health system is. It's kind of a concept that extends on the continuous quality improvement idea of being able to really self-reflect as an organization, but it's a bit more than that. It's a departure from the blame and shame culture of, oh, you know, we didn't do something right, to saying, hey, what can we do right, and how can we fail forward in the next cycle? These cycles, here's the DKP in this graph, you see that, or this figure, you see the data is that sort of, if you start there, you move to knowledge, and then the performance can be measured as a result of that knowledge, and it goes back to new data, and that's the DKP cycle. What I've sort of tried to illustrate here is a socially accountable learning health system, which would anchor around the partnerships. These are typically characterized by diverse representation across different organizations and different sectors. I'm going to put in the chat the sectors in what we call the partnership Pentagram Plus model. There's diverse perspectives is the key, and we can all learn from each other's perspectives as long as we come together with a shared commitment of social accountability. And we interact with this environment and ethos of appreciative inquiry, where we appreciate each other, and we are interested in hearing your perspectives to make the system better and to understand the data. There's a reference on the left here of the origin of this concept of partnership pentagrams and these key diverse perspectives, and a reference to one of our colleagues, Ray Markham's paper, and colleagues from First Nations Health Authority and RCCBC, published in BMJ Open in 2021. An equity-driven partnership focuses on access, equity. So looking under the knowledge, we want to learn about access, we want to learn about equitable outcomes, and we also want to look at equity through the lens of financial protection, which came up in one of our previous presentations, where we compare how much money people have and how much they are asked to spend for their health expenditures. So the DKP cycle is also really well known in the LHS literature. We move through the data. The data is the key, and being able to rapidly access this data and go through a cycle of learning is the whole driving force behind the learning health systems. So we do have access to administrative data, and we do have a fantastic infrastructure for qualitative interviews and surveys within digital emergency medicine. And with our partnership, our LHS partners, we have an evaluation framework for our TVS, which is guided by the objectives of the program. You can see the different domains. I'll walk you through the first top one. The RTVS aims to support patients and healthcare providers in accessing safe or collegial support in a timely and equitable manner. And that's called the access or the safety net domain. And metrics that we extract from the data, for example, under this domain, could be the number of encounters by region to look at geographic equity, and the distribution of access of encounters by socioeconomic status to get indicators of equity. And I'll go into that a little bit more in a minute. We also have the coordination of care guiding one of the objectives, where metrics like concordance with the recommended disposition are measured as from the data to give us knowledge and then to inform practice. We include the culturally safe feather domain to guide the RTVS goal to provide high quality, culturally safe care to Indigenous clients and their family members, and support care that is closer to home, as we've seen some of our previous presentations underscore the need for. The RTVS learning health system also is guided by an interest in building capacity and nurturing relationships within RTVS itself. And so one metric that we keep track of are the cultural safety training hours that are practiced within RTVS pathways and within our RTVS partner organizations. And a domain dear to my heart as an economist is the efficiency domain, or balance. And we've tried to look at the goal of balancing a cost-effective program with equitable access and other dimensions of equity. And the way we could start to unpack this really major question is to link to the metrics in the access domain, as well as the costs of healthcare service use, and what Graham mentioned earlier, cost to patients and their families. And if we're thinking of CO2 impacts, we could even look at cost to future generations. And we also hope for the RTVS learning health system to support recruitment and retention, and we keep track of providers that are recruited and retained, and particular in priority areas. So some of the results of this wonderful learning health system to date, I'll just walk you through. There's been 3 data to knowledge to practice cycles. In the first cycle, the RTVS network was established and an evaluation framework was born, very similar to the one I just showed you. From that work, mixed methods evaluation demonstrated the value of the virtual care pathways and the systems learning that could come of it. In the second cycle, the evaluation continued on to support a second annual report. We also were able to bring in some research at this point and have published an article called it's a preprint now, but it's a case study in Dawson Creek showing that the Rudy service could provide an option to avoid ED closures in Dawson Creek and to keep emergency services up and running. So there's a case study supporting that and really embedding that research into this learning health system. We also have an iterative dashboard where we can keep track of these evaluation metrics and other research findings. For example, we could look at the transports that we heard about earlier on that. So that was developed as a result of research funding from CIHR, along with the deliberative dialogue that came out of cycle 3. This is a wonderful open event. It was hybrid and it occurred this summer, hosted by DGM and facilitated by many members of our CCBC, as well as the First Nations Health Authority. And we tried to have each of the partnering organizations participate in the Pentagram Partnership Plus, and our result was a deliberative dialogue about equity-oriented access and a toolkit for improving equitable access to virtual care. And so these are publications forthcoming, but we do have another article that came out in year 3 describing the evaluation findings of year 2 and focusing on the equity and efficiency goals. And our year 3 evaluation is currently underway, where we are able to demonstrate social accountability with evidence from the data. So here's a little snapshot of our toolkit. We focus had our audience gave us a dialogue which came together to feedback information about what they want from virtual care. And the emphasis in our toolkit is about cultural safety and humility, with a real focus on decolonizing healthcare, and then embedding community learning with a bias and from us approach within an evaluation framework, and then actually using Indigenous-led frameworks that are part of the framework and a cornerstone that honors the cultural wisdom that's already in place and has a voice within these frameworks. And the quality of the partnerships, ensuring that virtual care is available for everyone. So this toolkit will be available for other learning health systems and other virtual care programs across the country and hopefully across the world, for anyone needing to learn about how to provide rural, remote, and Indigenous services virtually. This is another new finding from the year 3 report, where we're working on a metric to measure the distribution of access. And we call this the shifting the distribution of access. And if you think about what typically goes on with health services, in the status quo scenario with the blue bars, you see the distribution of people accessing services is most heavily weighted towards the most advantaged, and people with the most resources have the most ability to access health services. And what we think RTVS is able to do is shift the distribution towards the more people with the least advantages, particularly within geographic inequities, and being able to improve the distribution more towards the least advantaged end. And if you could imagine, you were to draw a line, and I'll try to do that now, between the least and most, you have an upward facing slope there. And in another line, if you shift the distribution, it goes downward. And so we would measure the slope of this line as the slope index of inequality, and that would be a metric that we'll be including within the evaluation framework. So hopefully I can resolve this. Sorry, got too fancy with the images here. Undo, clear all drawings. There we go. All righty. And so that's some really great examples of things coming out of the RTVS Learning Health System. Another really trailblazer in the Learning Health System application is the 811 HLBC 811 service that has been around for quite a while, but the backbone of the telephone service was leveraged rapidly in response to the pandemic and the need to prevent ED overcrowding at the risk of COVID-19 transmissions, where the HIDE, the HealthLink BC Emergency Doctor and Assistant virtual program, virtual physician services were launched rapidly within 30 days of the lockdowns, and the initial LHS cycle showed that the program was safe, and there was a research publication demonstrating that HIDE was one of the first programs of its kind in the country to safely divert emergency services to virtual physician services. Later in the next cycle, it was proven effective and able to safely divert 60% of all urgent calls to a virtual physician service. And then in the most recent Learning Health System cycle, we've been able to set ourselves up for failing forward by looking at what happens after a HIDE physician provides advice, and does the patient go and see a physician within 24 hours, for example, or attend ED as they were assigned to do, and understanding why, what patient characteristics can relate to this. And this article showed that geographic location and attachment to a primary care physician are key drivers of concordance with the ED disposition. So demonstrating that the Learning Health System is amenable to change. On the left, this 811 nursing line, you can see the systems learning that has come from these learning cycles. The HIDE virtual physician add-on was augmented with a pharmacy. The 811 service has the infrastructure to connect with pharmacists, and these could be rapidly brought together to distribute the antivirals during the time when Paxlovid and antiviral prescriptions needed to reach patients across the country and needed high-risk prioritization. And this distribution enabled access to many patients served by the RCCDC network, and then the infrastructure of that pharmacist has also gone to another learning cycle recently this year with the launch of the PPRSS, a prescription drug renewal line in response, and this is available to patients without a family physician. If they need their prescription drugs renewed, they can do so virtually through this 811 HIDE infrastructure. So amazing potential within both that infrastructure and research capacity. This is some research I'm leading with Dr. Kendall Ho with a CHR Catalyst grant, which we call Building Virtual Bridges. And our goal is to be able to provide an accurate and robust economic evaluation, and to be able to use predictive analytics to characterize the outcomes after a HIDE 811 physician call, and develop a method for accurately defining policy alternatives within the population and from the data. And this work is currently underway. I hope to have some results to share next year when we meet again, but it's a wonderful CIHR funded Catalyst grant, and in partnership with nested within this RTVS Learning Health System. So to tie it all up, it's been on an incredible journey through 3 data knowledge practice cycles of learning, demonstrating RTVS commitment to social accountability throughout. Research is at the heart of the systems learning. There's rapid access to data and knowledge through the partnerships, the governance and processes have enabled this research to reach knowledge users and liberated the data. In this year, we are able to now to ask key questions and allow for critical systems learning by failing forward and being able to learn from what could be better. And with a huge sentiment of gratitude, I represent my team. This is a wonderful research group that's put all this together within the DGM part of the team. I have to really thank Dr. Kendall Ho, Dr. Novak Lauscher, Joanne Asali, and all of these wonderful team members of the RTVS portfolio at UBC Digital Emergency Medicine. And thank you very much for the opportunity to share this work.
Great, thank you very much, Dr. Cressman. Dr. Woolard, do you want to expand on your erudite comment?
Don't know how erudite it is, but what's delightful, and considering your educational background, I really congratulate you on this of not reverting to sort of linear cause relationships and audits of what the impact has been, but being able to share with us the idea of social systems, of which the health system is one, like other biological systems, are complex. They're not complicated. The complicated stuff is like launching a rocket ship, and you can figure out when it blows up why it blows up. But you know, complex being like raising a child. When you've raised one, you've raised one. When you've looked at one small community, you looked at one small community. On the other hand, I love the way that you have developed and presented this with an engagement of folks and building folks into, with the various perspectives, into the feedback loops, because that's how complex systems work. And too often, I think the exploration of the healthcare system, perhaps understandably from the Ministry of Health point of view, often gets diluted to measuring things that don't matter.
Yeah, 100%. You know, I've heard the analogy of the learning health systems within an ecosystem, connected to the community at the roots, and this ecosystem, it's kind of like a living organism. It needs to evolve and respond to these threats. I think the pandemic was the classic example, but I'm thinking the launch of that Katie antivirals line, there's a sudden new important need that comes up to the front, and we need metrics to evaluate how that worked quickly so that we could do it again. And this is in constant connection with our environment, our digital times. Thank you very much for the comment.
Thank you. We'll turn things over to Nance Cunningham and Jessica Lamb.
Hello. Jess, you want to go ahead?
Yeah, hi. We are on. Yeah, so hi, I'm Jess Lamb. I identify as a person with lived and living experience of substance use in the drug war, but I'm also a survivor of hepatitis C. I was diagnosed back in 2017 and received treatment in 2018 before treatment was widely available. I work in Cranbrook. I'm in the East Kootenays on the unceded ancestral and traditional territory of the Ktunaxa Nation. And I work at Anchors, which is the AIDS Network Kootenay Outreach Society, as the peer lead development coordinator. So I do a lot of drug policy work and peer work, making sure people are engaged. And I'm also the co-founder and project coordinator of our local drug user network, which is the East Kootenay Network of People Who Use Drugs. Thanks for having me.
Hi, I am Nancy Cunningham. I'm a PhD candidate at UBC. And so I am on Musqueam territory at the moment. But this research was done all over BC in the unceded ancestral lands of many different Indigenous peoples. And we sincerely intend for this research to contribute to health equity in these territories. We have no conflicts of we two presenters have no conflicts of interest to disclose, but one of my supervisors received an honorarium from VIV. So just for a little bit of background, hepatitis C is a bloodborne infection, which is preventable and curable and affects over 50,000 people in BC. By affects, I mean that many people, about 1.5% of people in British Columbia have ever been infected with hepatitis C. About 30% of those cleared the infection naturally, and others got treatment for it, but still It's estimated that at least 25,000 people in British Columbia still need treatment for this high burden infection. And in order to deal with that, the health authorities in British Columbia have publicly funded testing and treatment unrestricted by liver stage in British Columbia since 2018. And the policy on testing and treatment is to test all adults born between 1945 and 1975 once, because they may have been exposed before there was a hepatitis C test available for blood, and because they may have had medical procedures before universal precautions were common. Also, to test people with a known potential past exposure once. So that could be a tattoo received in a country where the cleanliness of the needles is not ensured. And also to test people with potential ongoing exposures annually. With this case finding in British Columbia, they found that about 90% of cases found are uncomplicated and therefore can be treated in primary care. However, as we will see, they rarely are.
So Canada is committed to eliminate hepatitis C as a public health issue by 2030. Elimination includes 90% of cases diagnosed and 80% of hepatitis C cases cured. More treatment would be beneficial for individuals, and elimination would produce significant dividends as infections prevented and reductions in healthcare use. Canada as a whole was on track for elimination by 2030. However, BC was on trend to eliminate 2 years early by 2028 if recent trends continued, but those trends had started faltering before the COVID-19 pandemic. Most likely, patients who are easiest to treat were treated first. I have experience in that. And by easiest, I mean urban, engaged in healthcare, waiting to accept treatment. But that is not typical for all populations with high hepatitis C in distance. I don't know if I'm saying that right. Testing and treatment by rural care providers is necessary for elimination.
So this is a chart which shows new confirmed cases in hepatitis C in British Columbia between 2007 and 2019, the most recent figures available. The blue line you see there is British Columbia, and the orange line below is all of Canada. So we see that BC is higher, and that's due to two separate things. First of all, BC does have a higher rate of having hepatitis C than the whole country. Canada as a whole, about 1% of people have hep C. In BC, it's estimated at about 1.5. But also, these are new confirmed cases, not new cases. So this also reflects British Columbia's efforts at finding existing cases in order to be able to offer people treatment.
So in BC, in the last 20 years, about 80% of transmissions is thought to be via shared substance use equipment. And that could be like a gap in harm reduction or low treatment uptake among people who use substances. So substance use equipment is not entirely related to injecting. Hepatitis C can be transmitted by most shared items like smoking as well. Transmission is because of gaps in harm reduction, but also due to a low uptake of hep C treatment, because treatment as prevention works for hepatitis C. Less than half of people who use drugs test positive are actually treated for it. And men who have sex with men also have higher risk of exposure. Sex workers are exposed to the same risks as men who have sex with men, but do not receive the same attention in hep C prevention and care. Many sex workers, current or former, are unwilling to talk about their exposure because they have been shamed about their survival strategies. Before, I was a person who engaged in sex work, and during it was when it came time to talk about, because the doctors were like really interested in how I contracted hepatitis C, and it was really awkward talking about that with my mom in the room next to me. And they continued to probe to ask some like really unsettling questions about like, do I remember who I was with when I would have gotten it? And, you know, it just brought up a lot of shame and guilt for myself. And it just, yeah, they just kept on poking and prying and telling me, you know, because I was a person who used substances, I needed to be off drugs for a certain amount of time. And, you know, if I reinfected, like I only had one shot and all this stuff. So it was really not a very fun experience when having to disclose this to my care provider. So on this map, we see the distribution. So this map shows a combination of prevalent cases identified and incident cases, including reinfection. So all of BC is at 38 per 100,000. High rates in rural areas. So Fraser East, you can see is 61 per 100,000. Northern Interior is 55, and North Vancouver Island is 52. So, yeah, association with men who have sex with men and substance use may give people the impression that hepatitis C is a mainly urban issue, and even if they work in the sex trade. So people think it's not happening in my community. This is a danger in not recognizing that there's people who engage in sex work all over the place. Rural communities, work camps, small towns, it's all in our backyards. It can be a really easy way to make money when you're struggling. And I found myself, even when I wasn't engaging in substance use, found myself in a small community and engaging in sex work in a certain period of time. So it's in our backyards. There's like a rotation of people who go around. So low threshold clinics in urban areas like Anchors, like at the place where I work at, Hope to Health, provide Hep C care for uncomplicated cases. So we do things like Hep C testing, and then we'll link somebody to care. And we're really going beyond meeting people where they're at, but accepting people where they're at. And I think like I work in harm reduction, and that's something that's become really important to me in the last little bit. Is we say meeting people where they're at all the time, but I think we need to take it one step further and accept people where they're at and then work with them from there, because there's a big difference. So and then few people in rural BC have access to low threshold clinics. Primary care is key for access to Hep C care. And I think a lot of it has to do with stigma, right? Like being identified as a person who uses drugs or a person engaging in sex work, or, you know, we often see in the community that I live in that, you know, if you're a person who uses substances or living outside or engaging in sex work, that you'll wait a lot longer than other people in like a primary care clinic. They'll just leave you to the end of the day because lots of people just don't want to deal with you because you might be more more work than the next person.
So we're going to give you the results of a study here, and this study explored the experiences of people with a history of substance use or sex work to understand their engagement and experience in healthcare, like what Jess just mentioned, and to identify opportunities to reduce barriers and enhance facilitators of hepatitis C care. This is a multi-stage project, and we're going to talk about the first stage here. And the results are going to include community source solutions to inform continuing professional development materials for primary care providers in British Columbia, like a lot of you, I hope. And at the end of this presentation, you're going to get a preview of some of those solutions. So the way that the study was done is we took a qualitative approach called interpretive description, which was developed specifically for applied health research like this. We did a purposive sampling of 25 participants from all over BC. It was really important to me to have rural experience included and to have sex worker experience included. And we did that really well. There were 11 hepatitis C cases that were discussed. And then we did thematic analysis to bring out the themes.
So participants anticipated stigma and so avoided healthcare when risking their health. This perpetuated their health disparities. And participants in rural areas typically did not disclose Hep C risks or infection, and so were rarely tested or treated in primary care. This could be unwilling to be questioned about their past and exposure to Hep C, concerned about confidentialities and flags in their file. And especially in rural areas where people have used drugs or sold sexual services, do not want their history to become known, especially in a small community. Lots of times the people who are providing healthcare services might be a family member or a friend, or just running into somebody in a small town because they see you at a pharmacy or things like that, right? It can be really challenging in small communities around the confidentiality. And I just also want to bring up people who have children as well. Lots of times they won't disclose things like substance use or sex work or anything like that out of fear of having their kids taken away from them. And I think that's something that we really need to highlight and talk about, whether they've changed their relationship with substances or not. So primary care providers who knew of Hep C and diagnosis rarely initiated treatment. So 11 of the cases of Hep C discussed, only 2 people had treatment or were given encouraged by the primary healthcare setting. And as a person who works with people who use substances, I see this a lot where, they get tested, but then when it comes to treatment afterwards, lots of people are slipping through the crack for a number of different reasons, whether it be, just the surviving and trying to incorporate treatment into your care, or even a doctor not wanting, even though treatment is possible for people who are using substances. I know a lot of people will just not work with that person because they're still using drugs, and we see it a lot. So I think that regardless if a person's using substances or not, they should be treated for hepatitis C. But Hep C can be very serious or fatal. So it's important to encourage people to get treatment. So healthcare relationships influence participants' healthcare decisions. So understanding factors that threaten healthcare relationships can help you provide support for the real world needs of these populations with high Hep C incidence. I don't know if I'm saying that right, in prevalence. Many of these patients may be fearful or anxious. They might have felt stigma and shame in healthcare and are expected to be judged. I think I talk about this all the time, is that internalized stigma because of the criminalization of people who use substances and people engaging in sex work, that it's just, we're already carrying that societal shame with us already. So when we approach healthcare, if we can take anything, if as though that's directed towards us. So oftentimes in any healthcare setting, I always say check yourself, check your body language, because even not making eye contact with a person can make me feel like I'm dirty or bad or not good enough because of, I'm already carrying this shit with me, excuse my language. And then your body language, or you not smiling or not taking enough time, just adds those extra layers onto the shame. So and then they have a flag on their file for substance use, which can affect you for the rest of your life. I also want to note that people who use stimulants are often flagged as violent, when sometimes you just need to take a little bit more time with the person. So these flags are rarely removed even after years of not using substances. I know through my own experience, those flags are always on my file, and even getting pain medication can be pretty difficult for a person like myself who has existing opioid use disorder. So yeah, we very often keep a lot of these things to ourselves, and it really just comes back to that stigma and watching your body language and speaking kindly and just taking a little bit more time with folks. So participants suggested be expressive with your supportive attitude and follow through with the accepting practice. So, you know, you can tell me anything and it won't leave the room. That means that you don't write something down on my file, because if anybody else reads that file, then that means that I didn't tell you. I told anybody who's going to see that file going forward. You know, you don't need to be embarrassed about anything with me. I won't judge you. I've heard that before. And then, you know, they go in to ask me questions about like, oh, well, who were you with that night? Or like, how did you get it? Was it from injecting, or was it for, you know, engaging in sex work? Oh, well, we think it's engaging with sex work. Then, you know, all of those things, like at the end of the day, it doesn't matter how I contracted hepatitis C, whether it was from my substance use or for my sex work. Doesn't matter. The fact is that I have it and I needed to be tested and cured. And, you know, unfortunately, a lot of people are only getting these services when they're changing their relationship with substances. And I'm a huge believer in that a person doesn't need to be changing their relationship with substances to be able to access healthcare services, right? Like that is compassionate and wraparound care, where we just like meet a person where they're at. So really checking like your body language in these situations as well. You don't know, you know. I remember being at a pharmacy one time. This was when I first found out I had hepatitis C, and it was at my local pharmacy. I was new to the community. And when I told the pharmacist that like, this is my situation, I have hep C, can you help me find the medications on the shelf that I'm not allowed to take because of the medication that I'm on? But when I told him that I had hep C, he stepped back from me, right? And it was like, whoa, like, it's not like I sneezed on you or something, dude. Like, you know, I'm like, I'm just a human being asking for some help here. So really like, yeah, checking yourself and how you're presenting yourself in these situations. So yeah, take time to ask questions about my life. And yeah, just talking with, a lot of times these relationships take more than one meeting to gain trust in our healthcare providers.
Yeah, so the next stage of this research is to talk with healthcare providers, and that I hope includes some people who are here in the audience. I want to be able to talk about the experiences that you have had with treating hepatitis C or not treating hepatitis C, or being worried about treating hepatitis C, or also working with these populations. So I'll give you my contact information in a minute. But in the meantime, thanks to all the conference organizers, the participants here, and in the research collaborators, everybody. This research is done with a whole lot of people. So thanks for listening, and I'm very happy to take some questions. And you have here the contact information for this study in case you would like to be an interviewee.
Thank you for
And
this
you can
presentation.
direct your questions at me or Jess.
Thank you for the presentation, and thanks also for sharing it. We don't get to hear that often. I think the main takeaway as a physician who works at St. Paul's Hospital in downtown Vancouver, you know, is be nice to your patients, and it solves an awful lot of problems, and segues right into the question from Sandy Lee. What are the reasons why people are not being treated by physicians because of drug use? I'm curious how this information can complement physician practices with the spot test that is designed to assist diagnosing hepatitis C in rural context.
I think you have the answers to those questions, Jess.
Yeah, it's kind of a loaded question, right? Like, there's a whole bunch of different reasons. I think like stigma, like I talked about, like the internalized shame and stigma, right? Like, you know, you've been tested, you met with a doctor, that appointment didn't go well and you just never go back. We often see in this town that people, it's not necessarily like, you know, you go into a doctor and they're like, oh, I'm not going to treat you because you're on substances. It's that any doctor is just too busy to treat that person who uses substances, but will take on somebody who doesn't use substances as their patient, right? So I think that's one of the biggest things that we're seeing here in the rural and remote communities, because there's already a lack of access to doctors anyways, right? So just that extra layer of being a person who uses drugs just really kind of makes it really difficult to find care sometimes.
Yeah, the diagnosis with, the dried blood spot has been really great for rural area diagnosing in rural areas, but it's not very much used to be diagnosed if no one will treat you.
Great, thank you for this presentation. So next, I believe, is Dr. Kirk McCarroll and Matthew Lavery.
Hello, can you guys hear me?
Yes.
Okay, perfect. I'll just share my screen here and make sure we're good to go.
Are those slides showing up there?
They are not.
Hmm.
There you go.
Okay, Kirk, did you want to start us off and I'll take over?
Sure, yeah, if you got the slides there, Matt, that would be great. Yeah, good morning, everyone. Thanks for the invitation to participate in this. My name's Kirk McCarroll. I'm a family doc, and I work in the community of Revelstoke. Matthew and I, along with Jason Curran and our research nurse, July Wilkie, as well as another med student, Ryan Williamson, put together this research project that was put together in the traditional territory of the Secwepemc, the Sinixt, the Syilx, and the Ktunaxa. So I wanted to acknowledge that this work took place on that traditional unceded territory. What we wanted to look at was our use of appropriate CT imaging in patients within a rural emergency department. So in our community in Revelstoke, all right, just trying to pull up those.
Your slide is fine if that's what you're concerned about.
Yeah, sorry, I was losing all the slides there. They've all popped up again now. Apologies. Yeah, so we work in the community of Revelstoke, and we're a team of family docs. And one of the stressors that we deal with is in managing head injuries in our population. We work in a remote community in Revelstoke that's a significant drive to a center that has appropriate imaging for head injuries. In addition to that, we work in a community that has a high proportion of high-risk tourism activities like downhill skiing, mountain biking, snowmobiling, motor vehicle collisions. So we get a lot of head injuries. And because of the risk of transporting a lot of these patients, we often wonder whether or not we're imaging appropriately. So in our hospital, most of us will use the Canadian head CT rule for determining which patients should be transferred for imaging after a head injury. And as you'll recall, this is a decision-making tool that was developed in Canada to actually identify patients who probably did not need CT head imaging after they've had an injury. But by default, in a lot of the rural communities, and especially in Revelstoke, we polled our group, it's a tool that we use to make a decision as to which patients actually should be transferred for CT imaging. So with all of our head injuries, we wanted to have a look at our patients and decide whether or not we were providing appropriate care. And just as a background, this research sort of applies to many Canadians. 20% of us live in rural communities, and then 22.5% live more than an hour by car from a level 1 trauma center or an area where imaging is available. there's lots of recreational activities in these smaller communities, and we certainly see a high proportion of trauma and head injuries. So we always struggle with this decision as to which patient should go for CT, and most of the small communities really, when most of us, especially in Revelstoke, we feel we would benefit from local CT scanning. So in the interest of trying to demonstrate to determine whether or not we were providing this care, we put this research together as a chart audit, looking to see how well we were at following the standard of care and applying the Canadian head CT rule to our patients, and appropriately imaging those patients that really should have imaging. Go next slide there, Matthew, please. So maybe I'll let you take over here. Matthew did all of the work here in terms of designing the research project, and I'll let him describe how we endeavored to investigate our performance in Revelstoke.
Yeah, thanks, Kirk. So just to go a brief structure of how we went about it, we just did a retrospective chart review. We went back about 4 years through all the charts of Revelstoke, just to take the charts, apply the information that was included in these charts to the Canadian CT head rule in order to determine whether or not there was an indication for head CT based on the current guidelines and the current standard of care. And then we looked at whether or not these patients actually received transfer to a secondary facility in order to get the imaging. So what you see up here is this little flow chart of the data. So over those 4 years, we collected 141 charts that we believed met our criteria based on the primary coding as either concussion or minor head trauma. And then we broke these down into charts that were either included based on the inclusion criteria or excluded based on things that would exclude you from being a candidate for this rule being applied to you, which would be things like people who had unstable vitals or who had signs of a unstable injury or pregnancy, or things that would exclude you from getting a CT or being applied to this rule. So the big one here that we're looking at is going to be on this side. We had 124 charts that were initially included, and 77 of those charts met criteria and were indicated to have a CT scan. And based on this, we would presume that at most facilities that are CT enabled, that these individuals would have all received a CT scan. And then 47 of our total did not meet the criteria and therefore would not have been scanned. So for us here, we're looking at those individuals who had indication for scanning, and we see that only 35% of those patients were actually transferred for imaging, and the remaining 65% of individuals did not receive imaging. So moving on to the next slide here, we just have a quick visual aid to kind of show that overall. So with the Canadian CT head rule, it actually divides patients into medium risk or high risk. And that kind of suggests, I guess on the greater scale, a stronger indication for imaging in these patients. So if we look first at our medium risk criteria, we see that of medium risk patients with indication for CT, that we only were transferring 16.7% of patients who were intended to be imaged based on this standard of care. And for our high risk patients, we were only transferring about half of the patients that were indicated to receive this imaging. And this gave us our overall percentage of 35.1% of overall patients with indication for imaging who are actually receiving imaging. So that's just kind of the summary statement there, is that only 35% of these patients with indication for imaging were receiving the appropriate imaging. And this is lower than what we see on average. Most sites actually have the opposite problem, and they tend to see that people are receiving unnecessary imaging based on these guidelines. And clearly, as a site that doesn't have a primary CT in-house, we face the opposite problem. So it's a little bit difficult to directly compare our adherence to that of a site with a CT on site, as they too usually see suboptimal adherence, usually in the 65 to 80% range. But with their lack of adherence, it tends to be that they're over scanning their patients rather than under scanning their patients. a brief look into, it's not included here, but the positive predictive value of the Canadian CT head rule also shows that has about a 5% positive predictive value for detecting a secondary pathology or a more advanced pathology that would likely require further intervention and more intensive care in a hospital. So our numbers, we detected about 50 charts that missed imaging. And if we take that 50 charts and presume that the positive predictive value is accurate in our case, it actually leads to about 2.5 potentially missed pathologies over the time span that this study was conducted. So the big point here is that this kind of highlights that there is a little bit of imbalance when it comes to whether or not we're adequately scanning these patients. And like Kirk mentioned in the introduction, there's many reasons as to why we're not scanning these individuals. Obviously, the main one is convenience, and we don't have the CT scanner on site. But in a community like Revelstoke, there are significant barriers in order to transferring patients to receive that imaging. And those include everything from access to, I guess, transfer services to weather that can also inhibit people from being transferred. And one of the big factors for these communities as well is patient preference. And a lot of people don't want to be displaced large distances from their home in a one-way ambulance trip to receive an imaging for what they've been told is a minor head trauma and has a low risk of having anything to be significantly off in the first place. So that's kind of the big part there. And obviously we do acknowledge that there's a lot of clinical acumen and expertise that goes into deciding whether patients get transferred or not based on years of experience and training, and that rural medicine is not necessarily the same as urban medicine. But we do still believe that there's a decreased level of scanning in these sites, even when we account for the clinical acumen and the decision-making of these physicians, given that, like Kirk has mentioned, one of the main tools that they use to assess the need for CTs is still the Canadian CT head rule. So I think that is our time there. So if anyone has any questions, we're more than happy to answer.
Bob, I see your hand up. Am I jumping in for the moderator, or? I'd be happy to take your question.
I'm intrigued by your study, which I think is really important in terms of that. And I think you articulated well one of the challenge you have. But when you look at perhaps you underserved 1.5 patients over that period of time, it raises the issue, had you sent everybody down a winter highway through the mountains to get a CT scan, how much hazard would you have presented them to relative to this? So I think it's really important, but I think it's also important to put it in the context of alternatives. I mean, we've had this discussion in great detail around delivery, you know, with the tendency to centralize every kind of response and imagine that if they're delivering in a small area, they're problematic. But when you look at the overall morbidity, mortality, having your kind of expertise in Revelstoke is probably the most significant positive factor. And the absence of the CT scan shouldn't, in a sense, diminish the confidence of you know, in your capacity. So I just wanted to make sure that we had that total risk rather than just the CT risk.
Yeah, absolutely, Bob. And that sort of idea, that holistic risk of taking the patient and putting them on the road in that ambulance and risking the paramedics as they go and the patient's life on the road is absolutely the reason we hold on to these patients and we do not necessarily follow the rule. I mean, I think the main point of our research that I'd like to get across is that, I mean, technology has come so far with these scanners. You can go to most dentist's office now will have face and head CT scanners that they use, and it's really a bit absurd that the rural sites are not investing in these technologies, especially in sites such as Revelstoke, such as Golden, such as Creston, places that see these major traumas come in It's really, I think the health authorities are not meeting the standard of care for these patients by not providing these scanners locally. I think that's the main point that I'd like to get across with the research.
Thanks for sharing this. Do you have the outcomes of the patients? I mean, the actual, did they need a neurosurgical intervention or not?
We do not. Matthew, did you want to take that one? I don't want to hog the.
It's fine if you didn't, because if they go to Kelowna, you're probably not going to get it, right?
We don't. The idea of the study really wasn't to look at that. I mean, the Canadian head CT roll has been validated. So I think those numbers are out there in the literature. I think you can look through the literature and identify the patients that you're going to miss, just statistically speaking. So we did not, that was not the study question with this work. The study question was to select a gold standard, the gold standard being the Canadian head CT rule, and determine whether our group locally was meeting that gold standard when we provide care. So following them up, we did not, and we didn't have.
The reason I'm asking that is the Canadian CT head rule data is now a quarter century old. It was collected in major urban sites where your main issues are going to be falls from a height, and like high-speed MVAs are going to be your main sources of trauma, as opposed to some 25-year-old with a helmet who like snowmobiles into a tree. So a very different population. And again, what it shows me is that, the clinical acumen and even, like I said, like you pointed out, the number of patients who actually, even the CT head rolls, the number of patients who were scanned and actually had a bad outcome is close to zero. So things like serial observation is probably a better tool than just shoving everybody in the back of an ambulance down a winter highway where accidents do happen. Is this data published? That figure looked pretty like something out of a manuscript.
No, so our data isn't published yet. So we're actually currently applying for publication, but this is pre-publication.
Excellent. Congratulations. All right. Are there any other questions or comments from the audience? And I realize we've gone a few minutes over. Okay, well, thank you very much. It's been a real privilege to be allowed to sit on this for the third year in a row. Hopefully you'll have me back next year. Just terrific to hear what's going on, across the province.
Great, thanks, Frank, and thanks to you for moderating the session today. Thanks to all the presenters, the 24 presenters that we had in both rooms, or divided between the two rooms, and all the attendees for the questions and feedback. So enjoy the rest of the day. Thanks, and we'll hopefully see you next year for the 5th annual. Bye, everyone.